Capturing me, you. Just think of God. Just on Sunday. Why do you think I've got this? Yeah, I didn't need all of the sunny order.
Aaron, are we? It's 9:30. We're ready.
Bwrdd, Croeso I Gafon I Bwrdd. Good morning, everyone. Welcome to the Cyhoeddus University Health Board meeting. We will start by doing introductions and apologies. First of all, to introduce myself, I'm Judith Hardesty, the Vice Chair of the Health Board. I'll be chairing the meeting today as the Chair is away. So I have apologies from Ms Maria Battle, from Mr Lee Davis, Mr Mansell Bennett, Dr Barbara Wilson, Dr Mohammed Nazimi and Dr Hashim Samir. And we will have Paul Williams, who will join us during the meeting representing Lee Davis. And I'd also like to welcome Sian Howes from Ceredigion County Council. It's her first meeting as a local authority representative. And we will have Dr Warren Lloyd and Ms Liz Carroll joining later in the meeting, and Bethan Lewis, the Assistant Director of Public Health, will be joining for an item later on the agenda as well. Are there any other apologies? Okay, thank you. So can I ask if there are any declarations of interest? No, thank you very much. So we'll move on to the first part of the agenda, which is the minutes from the meeting on the 22nd of May. So can I take those for a correct record, if anyone has got any items to correct? No? Okay, thank you. We then have the minutes from the meeting on the 9th of June. Again, are there any items of correction from those minutes? No, thank you very much. So if we go to 2.3, we have the table of actions. I'll go to page 1. Is there anything anybody would like to raise on page 1? Page 2. Okay, I have a question on page 2 under 2278. The last 2 bullet points indicate they're completed in terms of immediate action They refer to a children and young persons review. I just if we could just have a clarification as to the timing of that.
So the Children and People's Service Review is the work that the Children and People's Group is overseeing. There's a particular review of community paediatrics within that as well, but the overall timeline will find another review that will be giving recommendations for next.
Okay, thank you. Is there anything on page 3? Page 4? Page 5?
In relation to the influence of the flavors, relation to dogs, so you look at the algorithm, excludes those players.
Yes, thank you, Chair. I can take that response. When we were referring to outliers, we were referring to a group of individuals who, by the very nature of the fact that they were in health board premises and were in infected wards or were subject to deprivation of liberty safeguards. But the nature of their need to be in hospital, they were in LD premises in a bungalow actually as a residence. So that meant that their deprivation of liberty was actually for very, very many months. Those individuals have now moved out of that facility, so this particular reference to outliers no longer actually applies. But it was really trying to indicate that in normal circumstances, the average length of course was about 2 months, but there were a group of individuals for whom it needed to apply much longer. Thank you.
Thank you. And so if we move to anything on page 5. And page 6, page 7.
Sure.
Yes.
Just on page 7, there's an item there. Sorry, page James. We're still waiting just for confirmation from West Highlands on that item. And we do have that confirmation. I'll get that shared.
Okay, thank you. Okay, so nothing else on the table of actions. Is there anything else from the minutes that isn't included that anybody wants to raise? Okay, thank you. So we'll move on to the report of the chair, which is there for information. I would just like to draw attention to some items on the report. The first on page 3, very sad to report the death in service of a colleague, and we express our sincere condolences to the family. I'd like to also highlight on page 5, there's a lot of awards that have been made to members of the health board staff, which is really very pleasing to see. Draw out the 2 Queen's Birthday honours that are listed there on bottom of page 5, and a whole range of awards that our staff have achieved, which I think is absolutely amazing and remarkable. We see all the hard work that everybody is doing. I'd also like to draw attention on page 10, at the bottom of page 10, that this is the last board meeting of Dr. John Gammon, Professor John Gammon, sorry. John is the only member of the board who was here now when I joined in terms of independent members. So it's a huge loss, but we will miss you. And I'd like to thank you very much for everything you've done for the health board. And I know you're not going very far away, which is brilliant. And also, you'll also see that we have lost Dr. Gareth John, who was a local authority representative, but we will be hoping to interview and make an appointment replacement soon. And finally, just something which isn't actually on the report, but just to remind everyone that the National Cyfarfod is in Tregaron from Saturday, which is very good news for the area. And if you've travelled up to Aberystwyth, as I have recently, there's posters all over the place, and it's really great to see. Usually about 150,000 visitors attracted to the Cyfarfod, so it's a big event. And there's an awful lot going on with our teams involved. So anyone who's up in the area who's able to visit, go to the stores, meet the team, and Alwena will be able to put out more information so you can have a look at the detail. But if you are in the area, I would encourage you to go. Okay, that's the end of the report. Is there any questions anybody has on any of the items? John.
Chair, with regards to accelerated cluster development, the board will be aware that we received a ministerial letter in March of this year, which clearly highlighted timelines for the development of clusters and professional collaboratives. I guess it's in the interest of the board and the public that we gain assurance that we're on track with that cluster development and the expectations of the minister.
Yes, I'm happy to respond to that. Thank you. It's a really important question, actually. I'm really pleased that the board took the opportunity of having that discussion at the board centre, and would welcome the opportunity in future board meetings to undertake more development work here. So I can confirm that there is an ambitious timetable, but there are particularly some requirements between April and September, for example, around the development of our collaboratives. So we have all of those collaboratives on track, including those that are not contractually mandated, such as therapies and community nursing. But there are collaboratives already under development for optometry, community pharmacy, general medical services and dental. The one that requires the most work, but that's the same across the whole of Wales, is the one around dental, because their contract has been the latest to be negotiated, and there is work to undertake in terms of bringing that collaborative together. But we have signed off terms of reference for our clusters and our pan-cluster planning groups. We had the benefit of actually having some structures in place in our previous way of working at county level, jointly with local authority and other partners in terms of Healthier Pembrokeshire, Healthier Ceredigion and Healthier Carmarthenshire. And those groups are going to be able to transition into pan-cluster planning groups, albeit with a refreshed terms of reference. So we've had much work underway to do that. I'm expecting the first cluster and collaboratives and the clusters in their new way to be meeting in August and September into the next round of pan-cluster planning groups. You know, as we talked about in many wards, this is really important for our population, because we have got that population assessment which has been signed off by the Regional Partnership Board. And although there isn't a statutory relationship between clusters and the Regional Partnership Board, it is within the terms of reference of the Regional Partnership Board. They pay due regard to clusters, and clusters are expected to demonstrate that they're using their resources to address the population needs that are identified through that market need, through the population needs assessment. So it's going to be extremely important for the Regional Partnership Board as well to continue to get those updates around the work of the pan-cluster planning groups, and actually how it links into our health board strategy. So there's that relationship through this. So I think this is an exciting period in our development. It fits very well with our strategic plan as well, but I'm confident that we're now well underway with the expectations within the letter. And I'm happy to get that sent around back to board members just to refresh everyone's memory in terms of what it says. But we report that to Wales at an All Wales level as well. And also, just for further assurance, every health board has to complete a readiness checklist, which we submitted at the beginning of June to Welsh Government. And that's got several pages of timelines available with very detailed expectations actually around development. So we were able again to confirm that we're on track with that. And there's an amalgamated, anonymised report back across the 7 health boards around that readiness. So I can probably share that as well for members of the like.
Okay, thank you.
I'm sorry, members of the public find it quite difficult to hear some of our board members. If you could just raise our voices a little bit, it's just not catching up on the microphone, sorry.
Okay, thank you. So a reminder, please speak up. Alison.
Hi, and John, just to provide some assurance, we had our first meeting yesterday, workshop to discuss the membership of the Allied Health Professional Collaborative, and will represent that collaborative on the analyst groups and the procedures as well.
Thank you, Chair.
I think we should be talking about to the September board, so I'm sure that will include an update on what Jim has told us. Thank you very much. Thank you, Jill. If there are no more questions, I'll move on to the Chief Executive's report.
Thank you, Vice Chair. It's great to be back in the room with you all today. I'm going to talk slightly loud because my voice tends to drop a bit. My nan used to say talk from the diaphragm, so hopefully members of the public will be able to hear, but apologies for those who are sat quite close to me. I wanted to start my report today with the very sad news that we were all aware of. The passing of Ros Jonas, our Director of Public Health, on the 3rd of June. It was lovely to see so many board members and other members of staff and friends and family at Ros's celebration of her life. Such a positive, very Ros-like event, I would say. And I know that board members will have Ros's friends, family and colleagues in their thoughts. I personally will miss her enthusiasm and her irrepressible optimism and of course her passion for public health. Her absence, I think, is felt keenly by the whole executive team. Her legacy, however, of shifting our focus to population health, I think will benefit West Wales for many years to come. And whilst many members of the public may not even know her name, actually I think they will feel the impact she's had on us into the future. And I think we are better off in West Wales because we have Ros with us. I don't want to spend too much time on the rest of the report. I am happy to take updates. There are a number of other important issues in there, and of course I'm very happy to take questions. But I did want to take the opportunity, if I may. I think this is a measure of the speed at which things are working to appraise the board of some recent discussions at our executive team meeting regarding our local efforts to significantly expand community-based care before we head into what we expect to be another very difficult winter. Board members will recall that at the last meeting, the Deputy Chief Exec brought the new planning objective in relation to this, and things have moved very quickly since we agreed objective. I think the need for such an expansion, firstly, was already agreed at all CEOs across Wales earlier in the summer, and we got that endorsed through the NHS Leadership Board at Welsh Government. And at a national level, I'm very grateful to the work of Carol Shillerby, the Chief Executive of Powers Teaching Health Board, for the work she's been leading on national efforts with this. And locally, we've had both Jill Patterson and Elaine Lawson working really hard with our local authority colleagues to agree on what our local part of that would be. And as I said earlier, this is moving really quite fast. So we had a very positive update last week, but there is still more to do. So the update that we received was very detailed about the work that we're doing. It identified the need as we go into the winter for around 52 intermediate care workers across Carmarthenshire and Pembrokeshire, the two areas most challenged in the community care part of our service, plus 15 joint apprentices. And I think that's the first in Wales that we'll be doing that with our partners. And I saw the adverts were going out just in the last week, so great to see. I'm also really pleased to say that the apprentices are 90% funded through the Regional Investment Fund and now within the summer. I think another good example of the way we are working together. And the local authorities and the health board have agreed in principle to split the costs 50-50 on the appointment of those staff who will deal with the immediate intermediate care needs of patients coming out of hospital. Of course, if there are longer term needs coming out, that will then fall to their local statutory responsible organisation, whoever that might be in that example. The cost exposure to us is around 550,000 this year, although that rises to over £1 million next year, and there is more work to do both on getting the written agreements in place and indeed to ensure that we have finalised the costs. However, at the exec team meeting last week, we felt that the responsible thing to do would be to start the recruitment now, whilst being clear that we shouldn't cross the line into making a commitment for two competing reasons. First is that the lead time on this is likely to be 3 months. Our workforce team does an amazing job of getting people through the recruitment process, but this, on top of apprentices, on top of overseas nurses, we just need to be realistic. we don't press the button on those lead times now, we will be deep into the winter before we start to feel the rain. The second, though, which is in the other direction, which board members will be very aware of, and we will talk about later, is our financial position. And there was nothing in our financial plan to cover this. And we are, as you know, we already are significantly challenged, which this may exacerbate. In the scheme of things, it doesn't sound like a huge amount of money, but it's on top of the existing financial plan. So I've got a couple of actions that I wanted just to get support from the board for today. The first is that I've already written to Welsh Government to set out what we're doing locally and to seek support. In the end, is a national initiative that we are planning. However, I would need to say to the board that given our financial position, indeed given the financial challenges across Wales, I don't think we can rely on that creating funding. And as an exec team, we have agreed that we are doing a rapid review alongside starting the recruitment process of the likely benefits, cashable and other, that we will get from what we think will expand our capacity by the equivalent of 90 community placements. So that work will go on alongside. What I would like to do, because things are moving at speed, is to seek approval for a chair's action between now and the September meeting. I'm subject to the chair's thinking on this. That will involve the chairs of the assurance committees as well, where we can set all of this out with the sponsor of Welsh Government, our plans to try and cover some of the existing resources. And we'll bring that to board, of course, in September. Apologies that it wasn't in my report. These things, as I say, are still developing quite rapidly. But the winter side of the harder progress, given what we're seeing already.
Okay, thank you. Sorry, I don't know what that noise was. Right, any questions for Chief Exec?
Thank you for the report initiative as we also quite talking. I think that it's important that we, therefore, given our financial position, we are able to identify where the funding for this is going to come from. Recognizing whether that is from other savings that we can make as a company. So I recognize that. On a slightly different tack, it's a variation, I guess, on what we did last year. But invest in the same shape. Our recruitment in that, we know perhaps not as good as we anticipated. So how we learn from that and what we did for this year, what we did last year, but building posts.
Yeah, I mean, yes, that's right.
Yeah,
I think
so I got another thing that Chippy was
yes. So yeah, I mean, right. I think the key difference this year, which gives us some optimism, is that these will be substantive contracts. You know, what happened last year was we were only able to offer fixed term given the nature of the funding. So that will help in that regard. However, I think it's fair to say that the employment market has tightened quite significantly. So there are reasons to be somewhat concerned about whether we can get all of these posts in. But I think we're setting out the most likely to succeed plan here. Successful. Starting now means that we can also keep pushing these if we don't get all this done.
More attractive to people to join just like some staff who originally
Yes, if I can just add as well, we are looking at a different recruitment process as well this time compared to previously. So we have been piloting a new drop-in style of recruitment. So we will be doing a whole launch programme in terms of attracting attention, and we will run a significantly different recruitment programme this time.
And if I may just have one other question briefly. Noted the contribution to our action. It's a relatively small amount of money, but it would be useful to have an update as to what we've benefited to buy from being involved in arts and contributing to why we should carry on.
I think a really good question, and it's something which has probably been going on, to be fair, in the background for some time. Of course, the obvious clear benefit we've had is the work that has resulted in the year regulation. Owl. So keep changing the name, we're in here, right? I was looking at John, then he was looking at me terribly. The Owl development the Pentre Isle development for Natalie, which will be a big step forward both for us but also for our local authority colleagues. I do think it's a point well made, and I think we need to take a report back probably through the Service Development Committee, the Strategic Development Committee, probably too, to set out what we are achieving and the future of that funding arrangement, because it has been going on for some time.
Winston.
Yeah, Steve, thank you very much for your report. I just want to draw attention to the continuing healthcare and funding nursing care fee uplifts. So what's struck me by looking at these were that first thing is that sort of the differential rate of uplift across for each county between general nursing and EMI. I wondered actually, are we inadvertently promoting and supporting some at the behest of others? But actually I noted that what your paper does is it does refer to a nationally agreed pay award, and I think we're just aware of what those might be. So the question might be how we'd expect those rates to change first one. Second question is more really about the timing in which Bang and Bristol are going to review these fees, when that will take place in the future. Because from my point of view, I didn't logically see a reason why there were differential rates between each county. And it would be good if they could be consistent. I'm aware that obviously each county council has slightly different positions.
I'm very blessed in my team to have an international expert on these issues. Jill, to answer.
Winston, I've tried to move from every job I go into, and unfortunately follows me. So anyway, I've been involved with this for very many years, and we actually did originally have a single rate for CHC many years ago. This predates Supreme Court and everything else. But we're always challenged when you go through a legal process in terms of the process, not the outcome. And it was always based on the inflationary uplift that we received or didn't from Welsh governments. And sometimes there would be an uplift, sometimes there wouldn't. And there was a challenge on that. And so we then moved to working with what was a model undertaken by the local authorities in terms of the way in which they can drive their fees, and link that then to the nursing fee, which is FNC, so that it would be more than FNC. It had some challenges to it, but it meant that we then moved into what was a historical position with each of those three local authorities. And their differences based on everything from capital and everything else in terms of how they work out their model. So we ended up with a model which links our FNC to our CHC. Now, when we then went into that Supreme Court challenge and were challenged on FNC, which is where the inflation pay award comes from, we all health boards that had that link were asked to move away from that joint arrangement around CHC and FNC going forward. But the danger of moving out of that is the work that we needed to do in terms of what is the alternative model that one would base their fees on. And that would be the legal challenge that we have. We couldn't describe substantial and robust framework. So we've continued, and Cody then got aware of that. Our finance team, our contracting team were leading that work. So we continued with that extant model, which is what you see today, and it again portrays those historical variations between local authorities. We have, through BRPB, had some conversations about moving together into a single position, but again, from the statutory local authorities and the challenges that they've had, they're very nervous about that, but they're working with us in terms of this land use review. So that is underway at this point in time. We're expecting that to report in coming weeks to inform our next year's position effectively. There may be some change to that, but we currently have agreed our fees for this year on the basis that you can see set out here. Now, the reference to the inflationary pay award is the FMC element, which is based historically on a national position, and that links to a band 5 nurse, midpoint of band 5 nurse. And so the FMC element is subject to change once we get that national pay award, which I think has probably been announced now. It's usually announced in around July. So we will affect any change that comes out of that. But our desire is to move into a model, again, that would be robust, would withstand any challenge, but that we can clearly describe the basis on which we've done that, and that's the basis of why we've contracted Land Leasing to help us to think about that model for the future. And the three local authorities are working with us in that arrangement, albeit at different timelines.
Thank you for a very comprehensive answer.
I think the Chief Executive undersold Jill's expertise and actually did represent Wales in the High Court. So if you want to know more, then I know Jill will give you a very comprehensive background on all of it. It's actually very interesting subject, but I'll move us on.
Well, as a comment,
Yeah.
it's good that we're recognising the wage increase
Yes.
and the cost of living increase, because these uplifts are closer to inflation.
Sorry, they have increased significantly this year, and every health board was expected to recognise the real living wage issue. So I wanted to confirm in public that we will be our health board and our local authorities have done that, and we hope that it will make that difference, because our care sector providers are an important part of the provision of our care ability actually in terms of.
Thank you. So I can't see any more questions, so we'll take us to the recommendations on page 5. There are 4 listed there, which I won't read out, which people are happy to accept those. And then the additional one is, as described by the Chief Executive, for us to approve that Chair's action is taken as described by the Chief Executive, and that a further report on the issue of the home care service is brought back to September board for endorsement. People content to accept that additional recommendation? Thank you very much. Thank you, Steve. So we're now moving on to item 2.6, which is the report from the Audit, Risk and Assurance Committee with a number of attachments.
Thank you, Chair. What could be better than one audit committee report? Dealing with them in chronological order. First of all, can't do. Sorry. First of all,
Can you take it off?
Oh, great. Thank you so much. Okay. First of all, dealing with the meeting from the 9th of June, just one issue that I'd like to highlight from that meeting, and that's in relation to partnership governance. That's code for RPB, effectively. And it's the point that we make about the absence of any independent or significant independent audit of the work which is undertaken by the RPB. That's not to cast aspersions on the work which has been done. It's just from an assurance perspective, there's a significant gap, it seems, to the members of the committee in the work that the RPB does and how we gain assurance about that. And that's not just applying to us, it should apply to the other partners as well. And that's an issue that I've raised previously. Moving on to the meeting from the 21st of June. The report is hopefully self-explanatory. I would just like to highlight the section in relation to external validation and the exercise which was undertaken at not insignificant cost to the health board to validate the waiting list. And the final sentence in that section of the report, I think, is perhaps the most important that we want to highlight, and that's the need for there to be lessons learned from this exercise, so that the scope and need for the exercise is perhaps reduced in the future, in order that we can make sure that the list is kept in a more up-to-date state for the future, rather than us have to invest significant resources in checking something which perhaps we should have a better idea what it looks like.
Thank you. Andrew, do you want to come in?
Yeah, on the external validation issue, I think there's a couple of issues here. One, absolutely, I think in terms of the lessons learned, that's something the service are clear that we need to pick up and make sure we embed across the service. We have, as part of our recovery plan and the money we've been allocated from Welsh Government to support recovery, I appointed to, or in the process of appointing to, an experienced individual that will lead that validation team effort. And we're very pleased that we've been able to secure them, because they're very experienced in this field and have done lots of this across the UK. And we've worked with them before. The other aspect to this, though, is that in terms of the volume and the cohort that we would need to continue to validate, we do not have the capacity within the internal health board team to be able to keep on top of the total cohort that is there, that we would want to track. Welsh Government are actually advocating in conversations with us that one action that all health boards should be looking at is external validation to support the management of the current waiting times position. And in our recent feedback on our submitted trajectories from June, there has been an offer that they're looking to secure at a national level a company to come in and support a number of health boards, and they've offered that that opportunity to us. We have a meeting that they will fund. We have a meeting later on today, end of today, with the National Plan Care Recovery team in Welsh Government and the National Director that's leading that work to review our current plan, and I'll understand more of the detail around that validation offer after that meeting and through that conversation. But that, you know, I just wanted to be clear that within our internal capacity, we would struggle with the staff we've got to be able to do that completely as an internal effort, just because we're talking over 100,000 records in the cohort, really.
Sorry, could I just make a point in response to that? I think I accept that, but I think what the latest exercise demonstrated was that what we were not doing was keeping an accurate record of those patients who should be on the list, and that was something that was at a point when investigations may be being carried out into whether a patient needed a particular form of treatment. The record wasn't being kept accurately, and there were therefore patients on the list who didn't need to be there because they didn't need any further treatment, and that element is very much within our own gift. That's not a volume number, that's about a process issue about we think we should be getting right.
No, absolutely, I fully recognise that, and that's the appointment that we're going to make will help oversee that and make sure that becomes less of an issue.
Okay. Are there any other questions on the two reports? Oh, sorry, thank you. And we're also asked to approve the terms of reference of the audit assurance committee. Everybody content to do that? Thank you. So we move to the second part of this item, which is the revised standing orders, standing financial instructions and terms of reference. These have previously been scrutinised at the audit committee. We return to the board secretary for this item.
Yes, Chair. So it's the annual review of our standing orders, scheme delegation and advice, as you slightly said, have been to the audit committee. There are, however, a couple of minor changes that we do need to make to the scheme of delegation in respect of 20.2.2 in relation to charitable funds and what is delegated. If you're happy, Chair, to approve them through Chair's actions after there are just 3 minor changes, otherwise they are there for approval. There may be some further changes as we move down the line as well to the appointment of the Director of Public Health for Chair as well.
Okay, thank you. Everybody content to approve those with the addition of any amendments being through Chair's action? Yes. Thank you very much. We do pass over this item quite quickly and it has been scrutinised, but I just want to thank the teams involved in Joe's department in pulling all this together. It's a huge piece of work, so thank you to everybody.
Just wanted to comment on one minor issue. Yeah, I absolutely agree. It's an enormous piece of work, but I wanted to leave it to this item to also give my thanks to Professor Gamble. And the reason for that is because although it was 2 meetings before I arrived, the first meeting that Professor Gamble attended for the health board, I think he was less than impressed, shall we say, with the scheme of delegation that he was presented with at that meeting. And I'm hoping today, partly down to the work and the input and his wisdom of the last 8 years, we are in such a much of a better place. And I hope this scheme of delegation gives you somewhat more assurance now than the one that I presented 8 years ago.
I have nothing to add, Chair.
Pretty good say he's less impressed with you.
I wasn't there.
Oh, okay. Fair enough. Okay, thank you. Thank you, everybody. So we'll move on now to the next item, 2.6.2, which is the risk management framework. And again, turn to you, Joe.
Chair, I'm not going to go through the detail of the framework as it's been scrutinised through the Audit and Risk Assurance Committee. It's also been shared with all board members prior to today and has been through formal global consultation as well, Chair. So it's here for approval.
Okay, thank you. Everybody happy to approve the framework? And just record thanks again to Charlotte and the other members of your team for all the work on this item and getting us to the position of having this framework. Thank you. Okay, so we'll now move on to item 2.7, which is the Quality Safety Experience Committee. Anna.
Thank you, Chair. So this is the report from our meeting on the 22nd of June. If I can highlight a few things, please.
I think, can you speak up? Sorry, I'm getting signals.
Okay. Just to highlight a few things from this report, if I can. The first is to call out some really positive work happening in our maternity services around assurance and improvement in light of a number of local and national triggers for that work, and we've been really impressed to hear about that progress through the committee. So I'd like to highlight that positive work that's going on. In terms of a couple of escalated risks, the board will note that we are highlighting the unscheduled care risk, which is at its highest rating, and I believe Andrew will be picking up on the latest position on that in his operational report, so I'll leave that for now. And also to highlight that while we continue to hear about the excellent work happening in our stroke pathway at an operational level to mitigate risks, the strategic issues that we are very familiar with as board remain, and it's, as we know, important for that strategic work to remain close scrutiny of the board. There's just one minor correction, that the next date of the committee is in fact on the 9th of August. We have terms of reference, which I'd like to ask board approval. And then continuing in the vein of previous comments, it was an omission on my part to recognise that this meeting was John's last. And I'm not going to go on to spare his blushes. So for the third time in this morning's session, John, I'd like to correct that record. Thank you enormously on behalf of the committee for all your work, both as a former chair and a committee member. And we will miss you enormously. So thank you very much. And I'd be grateful if I could capture that today. I'm happy to take any questions.
Thank you very much, and I'm sure we all endorse those comments. Mandy.
Yes, if I may, I'm not going to say anything, John,
Speak up.
embarrass you, but it's just, and I don't know how I missed this when we were doing the factual accuracy check on page 2 of the report. It's just to say that my title is slightly incorrect, but it's just for accuracy purposes. I get called many things and I'm quite happy with that, so just wanted to point that out in case anybody spotted it.
Okay, thank you very much. So any other questions on the report?
Yeah, can I just make a comment? One of the things that we discussed in the committee was the maternity services action plan and the update. And I think for assurance for the public, it's reassuring to me and other IMs that not only as a board have we got our own action plan in terms of what we feel we should be doing to ensure safe and excellent services, but we've also got an action plan to the Oakenden report as well. So we've gone further than what is expected, and I think that's commendable to our maternity staff for what they're doing in terms of a very reassuring action plan that's in place.
Yes, thank you. Thank you for that. Okay, so we're asked to note the report, but also happy to approve the terms of reference. Yes. Okay, thank you very much. So now moving on to section 3 of the agenda, and that's the board assurance framework. Exec.
I'll just say very briefly, but then hand over to the board secretary, just to say the team in the background, on top of what they always have to do at this time of year, have also completely revised our board assurance framework in light of the annual 3-year plan that we've been put in place. So a huge amount of work going on that, and I'll hand over to Jo just to take you through.
Yeah, thank you, sir. I will be brief, Chair. So members are on the link to the dashboard as they always do within the paper. And as the Chief Exec's noted, we have fully reviewed the back in light of the board's decisions over the last month or so. The committees have also received a progress report and all the POs aligned to them. And we're in the process of just making sure now that everything is planned in again for this year. We're going to be reviewing those tomorrow. And there are 3 that are showing that behind schedule, and those are related to the integrated and staff wellbeing officer, if I'm writing, the health inequalities and the non-life strategy that are slightly behind schedule. Again, they've been reviewed in committee chair, and the principal risks have also been reviewed with some of those will be changing over time as well. So happy to take any questions, Chair.
Okay, thank you very much. Any questions on this report? Yes.
Thanks, Jack. Mine's very specific. I could ask on page 4 under strategic objective 1, final bullet includes some data which refers to 74% of staff reporting being happy in their work. I just wonder if somebody could just expand on how we reached that conclusion from the engagement.
So if I can answer that, every month we do a survey of 1,000 staff, and that is one of the questions that we ask our workforce in terms of do they feel happy in their job. So the response collected every month is what's used for that percentage. So it is just a random sample of 1,000 people, and the idea is by the end of 12 months we will have surveyed every member of staff.
So it's different from the engagement, even though the reporting is connected with that.
Yeah, the engagement score will be collected as a result of the questions that are asked. Okay. So it's the same methodology that's used in the NHS Wales survey as well. So we just repeat it every month.
No other questions? Thank you. So we're asked to seek assurance from this report. Everyone content to do that? Thank you. So we're now on item 3.2, which is the improving patient experience report.
Thank you, Chair. I won't go through the detail of the report, but I do want to highlight a few issues within it. So just to say that, as I've said previously, we've been taking steps to try and amend the format of the report. It will be an iterative process, I think it's fair to say, based upon feedback that we receive about it. So it does look different this time, and one thing that has been helpful, I believe, is that we've aligned it more to the Improving Experience Charter that as a board you'll recall we approved previously. And I think what it does do in the way that it's set out is it exposes or makes more transparent areas that we need to put some further work and effort into. In particular, and I think although I've been reporting on it at each meeting, the area that I particularly want to undertake some further work on is around dignity and kindness. We will know that those are particular values that we hold dear as a board, and it's not providing through the feedback responses that we've had, and we've had a considerable number of feedback pieces of feedback through the various mechanisms that we deploy. I would hope that we could see an improvement in both the dignity and kindness scores that we have here. On the whole, the feedback is positive, but there is definitely more work that we can do. The other thing that I would want to call out is that we're very grateful that we have patients and family members who continue to share their experiences with us. And I'm very pleased and grateful to Sheila, who is identified within the report, who is a former healthcare professional themselves and therefore experienced in understanding the healthcare system. Nevertheless, her experiences have highlighted the importance of ensuring robust communication across the system when care is transferred between acute, community and primary care. And that is something that we're actively looking constantly to try and improve. The other story is from Zoe, obviously quite graphic in terms of her experience of her labour and giving birth. But I think what it does do is remind us that as healthcare professionals, it's just another day in work for us. But for individual patients, and certainly this came across in Zoe's story, this is a unique experience for each individual who receives care. So I think making sure that we as professionals go about our day-to-day duty, remembering that people can feel upset, frightened, anxious, is something that we need to put in place, and in turn will help us hopefully adjust the kindness scores that we're seeing. The other thing that I just want to call out is obviously the continued good work of the Arts in Healthcare team. And as you will be aware, recently we've had to restrict visiting, but the team, through strict infection prevention control measures, have been able to support and provide relief for our patients in some of our most critical areas. And I know that that has been extremely warmly received by patients in those areas as well. The other point that I just want to give some reference to, which isn't covered in the report, is a very recent distressing situation that our communities have faced, particularly in Llanelli, Kidwelly and Pembury, which is the circulation of some very distressing leaflets relating to a personal experience, but also a photograph of a deceased individual. We are very aware of these leaflets. We have engaged with the police and we have tried to reach out to anybody that has been formally distressed or actually distressed by the content of the leaflet. We opened up our communications centre to be able to receive calls from any member of the public that wish to speak about the experience or the leaflet themselves. And we have also made sure that we communicated and provided an update internally to our staff, who ultimately are also members of our population as well, because I'm very aware that several members of staff have been distressed by that as well. So I just want to acknowledge that we are aware of it, and that, so that our public are aware that we are taking this very seriously, but also that anybody who is distressed, please get in contact with us. But I'm happy to take any questions about the report or any points that I've raised.
Okay, thank you very much. Are there any questions on the report at all? Yes.
Just on the final point, I think it's implicit in what you said, but I think we prefer that the some individuals or staff and say service areas that are specifically identified. Presumably those are receiving support.
Absolutely. We try to reach out to everybody that is still alive, that is referenced within the letter or the flyer, to offer that support. Ultimately, as an organisation, we are unable to take action on their behalf. They have to take the action independently, and we are supporting individuals to take that action if they so choose.
Yeah,
I think for future vision, one suggestion might be that we perhaps seek to identify areas where, against a number of the measures which we've reported against, is that they using not at the top of the league table as in relation to a number of them, and similarly areas where they are at the top of the league table, so that's good aspects of the measures are concerned, and just to highlight that, and maybe in the same way you said we did, we could have some information about the action that we take or how we disseminate the good practice, which might be identified as a problem.
Absolutely, yes, no problem at all.
Okay, I just want to make a point. I mean, first of all, to thank the people who shared their stories and agreed for them to be published. I think it's, yeah, it was quite graphic and took me back, but still, I suppose one question is sort of how we've learned from that experience, particularly recognising, and I think it came out of the Ockenham report as well, not listening to mothers, and this may well have been a first time mother, but also, you know, knew what was happening to her own body. So I just wonder if you could just expand a little bit on what's happened as a result of this one.
So it was highlighted through the previous discussion about the maternity improvement plan. This feedback is captured, and thanks to the Civica system that we've now rolled out across the organisation, it's very much more real time. This feedback has been shared with the team, and there are improvements that I know that certainly the new head of midwifery has got a list of actions that they're taking forward locally with the team, and certainly the active engagement with the women's liaison group, whose name I can't just get off my tip of my tongue, is also really important for us, because we use that as a mechanism both to receive further information and feedback, but also to provide information about the changes that we've made.
Okay, thank you very much. So thank you. I think we welcome the report. I think some of it's a bit hard to read on the
Yes.
pink.
Yes,
It's just the comments I think I'd made.
yes.
So-
We will amend the colour scheme. I've already picked that up with Louise.
Thank you very much. Trying to get everybody to agree in the colour is impossible, but it was
Yes.
quite
But
hard
it
to
is,
read.
it is important that it is readable for individuals. So
Yeah.
that is something that we will take back, because particularly from an RNIB perspective, the reason why we changed the format is to try and make it as user friendly as possible, and that is really important. So we will be taking that back.
Great, thank you very much. Thanks. Yes, sorry.
Can I just ask very briefly, Chair? I'm conscious when we read the narrative accounts from patients in this report and in others, that very often issues of communication between different multidisciplinary professionals involved is flagged by patients. And I'm trying to see where we'd have a metric. I appreciate it's not straightforward to do that, but I'm looking at the chart and thinking actually there isn't anywhere there where we actually say that patients can expect that we'll do that coordination for them. What ends up happening is they struggle to do that in a way that really we should be taking care of. I just wonder if that's food for thought and perhaps something we could take back into our policy committee for further consideration.
Absolutely, and I think that certainly where we're looking at the measures around providing safe and effective care, that's where it sits for me, because if there's a breakdown in communication, that can lead to unintended consequences, including delayed treatment, harm to the patient, or not accessing the appropriate care at the right time. So yeah, I'll pick that up and look to see what we can add in to the existing dashboard that we got.
Okay, thank you very much, everyone, and thank you, Mandy, and we're asked to receive the report. Okay, so I'm now moving on to 3.3, which is the annual plan with quite a number of details attached to that, and I'm going to hand over to the Chief Exec.
Thank you. So I'm presenting this today on behalf of Lee, who's taking up some well-earned and overdue leave. And of course, the board will recall that we brought an earlier draft to board in March, and we've been since then through various seminars and updates of the board, keeping you appraised of developments. However, what you see here today, a great deal of work has now gone into this to finalise the planning objectives, all of which I've now signed off individually with the executive leads, and to develop all the specific plans and timescales underpinning them. There are, however, still a few small gaps for the eagle-eyed amongst you, which we will correct in the next couple of weeks through the plan, and I'll pick that up with Lee on his return. Just to recognise the board has had a number of sessions throughout the last 6 months, and we have walked through the detail. I'm not going to go through the detail today in public forward, but I think it's useful to put that on record. There are, however, a number of important points I think that I'd like to draw out for the board and looking at our current position and forecasts. I think firstly, the first point I would make is that this remains an exceptionally complex planning environment, both due to the unprecedented, multifaceted challenges the NHS is facing right now, including in West Wales, but also the scale of the challenges that we are attempting to make in light of these to radically change our delivery models at fast pace, whether that's in urgent emergency care, planned care and cancer, or indeed areas that are also close to our hearts, such as staff support and well-being, the things that are wrapped around essentially our target operating model and local COVID responses. This means that whilst we've got the actions set out here, and I think these actions are the right ones, and in some areas actually I think are groundbreaking, I don't think yet we've been able to adequately translate them into the financial and performance benefits that can demonstrate how we're impacting on the quality, safety and experience of our staff and patients, and indeed improving on our concerning financial deficit forecast. And I know this is also a significant concern for Welsh Government, and I think we should acknowledge today that given where we are, that may lead to an increase in our escalation status. So whilst recognising everything that's in the plan, all the good work going on, I'm going to propose a change to our recommendation at the end of the SBAR, and also a set of further actions for me and the executive team to pursue in the coming weeks. I'll start with the further actions, if I may. So the actions we're going to take as a team. I'm going to write a further accountable officer letter to Welsh Government in light of today's discussion. In that letter, I'm going to ask for the financial delivery unit to come in and give us some immediate support with the translation of our planning objectives into the impact on our finances and performance, and to work along our finance team to do that. I'm also going to ask the delivery unit and Improvement Cymru to review our planning objectives to ensure that everything that we're doing are ambitious enough, are covering the issues, and that we are able to provide the assurance to them around the underpinning actions that we're taking. The sense I get on that is that Welsh Government are very supportive and have been very positive about what we're trying to do. So I expect that to be largely a desktop exercise, but I think another set of eyes on these things from outside of the Health Board, I think will help just to clarify and give us that assurance. I'm also going to seek to establish a monthly meeting between the executive team and Welsh Government colleagues to overview, scrutinise and for them to challenge our progress on the quality and safety, performance and impact analysis. And I haven't yet had a chance to check with the Vice Chair or indeed the Chair yet, but I'm also proposing that we re-establish the weekly IM's briefing update that we had during the COVID response, so that we can keep IMs apprised of what is quite a fast moving situation. Of course, that will be in addition to and not a replacement for our standard scrutiny processes through our insurance committees, which will continue to do their work. The recommendation I'm proposing for the board today, and the board secretary has captured this for me, and can make sure that we share it, but I'll read it out to you and just get any immediate feedback. So I'm asking the board to approve the planning objectives and supporting actions as set out in the plan. But as a board, we require a further update in September regarding the translation of these objectives into the key deliverables of quality and safety, performance and finance. This paper should also set out the choices that we can make between these three elements, because there is trade-off between those. With a view to that paper describing how in year we can both start to reduce our in-year and full-year deficit, improve quality and safety and the performance of our system. And furthermore, I would ask the board to approve the recommendation that this update is subject to a full scrutiny of the relevant committees prior to the public board meeting at the end of September.
Okay, thank you. It's really helpful. Do you want to get an immediate impact reaction to that, and then we will need to move into any specifics. So can I have views from people on those additional recommendations?
Do you want me to read it again?
Sure.
Just an initial
Yes, just an initial
reaction. I think that's welcome. I think it recognises the difficult position and serious position we find ourselves. I recognise the time scale as well. I think we do, however, probably to recognise that given where we are in the year already, by September, we've only 6 months left in this year, and therefore the choices and opportunities for us to make much different, particularly in the financial position, I would suggest, between now and the year end, will be limited. But we will clearly do what we can in order to address that situation.
Yeah, I think entirely reasonable and sensible approach to take. I think offering the Welsh Government to come in and work alongside us, I think is an excellent idea. Because the perception is that they don't truly understand the uniqueness of the demands and the field our area is. I think by drawing them in to provide support and encouragement, that'd be a good move to make. I wonder about the commitment this means on the executive team, because I think in resolving the plan and where we go forward, it's going to be very important for the exec team to liaise with clinical colleagues, senior clinical colleagues, and operational colleagues, such that we don't get the exec team moving at a particular pace, like the nations trying to trail behind. So I think we just need to be cognizant of that, such that the overall visions of the plan are owned throughout the organisation. But I think planned briefing is really welcome, as much as possible for us to provide assurance and also support and also drawing our expertise as much as possible. Oh, so yeah, I endorse everything that
Just on one point to reassure the board, because whilst it is very challenging out there for our frontline clinicians and managers, the planning objectives, the things we are doing to the system are being done in partnership with our frontline. But I think you're right though to flag that in trying to translate that into the benefits we will get. There'll be a particular challenge, I think, for the finance team to be out there through the finance partners to be able to try and describe some of that. And it is very complex because there are so many moving parts. But I think we've got to make an effort to do that and improve it as we go along. We've got to do that in the next few weeks. And that will require some input and thoughts and the wisdom of our frontline staff to ensure we get that.
And just one more thing, Chair, I just think about our representative partners and others as well, because they have an impact in terms of our clinical aspect of our policy set.
Can you just speak up a little bit, please?
Okay, so just to make sure that we somehow bring our partners on board as well in what we're trying to do.
Absolutely.
Thank you. I've got Anna and then.
Thanks, Chair. Yeah, Steve, I think the actions you proposed preempt a number of questions I would otherwise raise. I guess what I would really hope that the extra sets of outside eyes could give us is their take on how we can move this bigger plan of strong component parts into a coherent whole, where we join the dots between all these different innovative things that we're doing and the anticipated benefits that we expect to draw from that, and how we track that progress and make the adjustments we need to over time to ensure it's very dynamic and coherent in cohesive in its approach. That I think is where we could really do this in extra.
I think that's spot on, and I think that's the key concern for the Welsh Government. It's not that all the actions that they see us taking are really good actions. How do we bring them together and describe the impact on the system?
Thank you. Thank you.
Yeah, thanks. Totally agree with the recommendations as Steve's outlined. I think Winston's kind of touched upon it in terms of our strategic objectives are clear in terms of objective 1 is about people, 4 is about communities. Whilst it's great that we are looking to engage with the front line as well as our kind of colleagues in central government as well, I think let's not forget our communities and those kind of partner organisations below local authority level as well, because they will be intrinsic in terms of how we deliver and may have alternate solutions available to present to us, perhaps where there's already perhaps something already in existence at a local level, which we could perhaps then exploit and escalate to the benefit of the wider population across the whole of our region. So I very much welcome the approach that's been suggested, but I think we could go a little bit further and perhaps not just look internally and to the usual suspects in Welsh Government, but also look within our communities where there is so much innovation. We saw that through COVID, that they are really being empowered in terms of how they can act with strategic partners to make a sustainable difference. And again, the experience of IMs and the connections that we all have within communities, knocking at an open door.
Yeah.
Just a brief response. Yeah, I think I absolutely agree. The planning objectives we have in relation to strategic objective 4, which is around our communities, you're right, are centred on how we work with those communities. So I think they're the right things for us to be doing. However, we do need to be open to the DU and maybe others saying there are some things here that you haven't done that you could do, so new planning objectives. I think, again, it's part of the complication of that is how do we translate that into benefits in the terms of which we are being held to account, which are our performance of quality.
Okay. Can I ask a specific question as well? It's sort of similar to the theme that Ian's raised, but I suppose I'm thinking more about the benchmarking of how we're doing, as we're looking at Andrew, really, in terms of some of the target operating model that you talk in there about ensuring we utilise our assets to the greatest extent. That will the DU bring us the evidence to say we are doing as much as possible? We benchmark well with our activity performance.
I think I suppose the starting point for that is in terms of target operating model. A significant chunk of what we're describing there revolves around how we reshape our urgent notice care system and our programme for transforming urgent emergency care across the health board. I know the feedback we've had nationally from Welsh Government is that the plan we have and the focus we have around frailty, in their view, is groundbreaking in terms of what it's looking at now. There is a need for us to be able to translate all of that analysis and action that is based on very good evidence from and benchmarking data drawn from across the world. We need to translate that into action. That's the challenge we've got. But I think that so it depends on what you're looking for them to come and compare and benchmark us on. I suspect in terms, as we know, in terms of performance and metrics, as outlined in the IPAR, there are obviously areas whereby we would all recognise. I would recognise that our actual performance benchmark doesn't hit anywhere near the mark that we would want as a board or expect as a board, and I wouldn't expect as a director of operations in the organisation. But in terms of the actions, I think the actions we're taking will stand up to scrutiny, but I'm also open to the idea, and I've expressed this, if there are things that anybody thinks that we have missed, are focusing on too much at the expense of things we should be focusing on more, or not picking up at all, then I'm open to those suggestions. I've not been offered anything yet.
That's fine, thank you.
So just to add to that, if I may, I think I know the board feels this keenly, and I think Welsh Government have this as a key concern themselves. It's our inability at the moment to connect all of those really interesting actions and really innovative things that we're doing on a whole range of issues into what consequences will be patients, for staff, and for the money. That's the bit I think we need to address very quickly. I'm sort of optimistic, because I am always optimistic, as you know, that actually we've done this sort of in the right way, and that we are focusing on actually changing the system. But the bit we haven't done is in the background, is to build the modelling around what that will do, and we need to correct that. And in some ways, notwithstanding Winston's concern, which I share about being able to engage with a very busy front line, in some ways that's an easier thing to do than to try and describe a change in a system that hasn't got any real action behind it, which is going to make that change happen. So I'm optimistic. I wish we were about 2 months before where we are now, but we will race to catch up, and that's part of the reason I'm taking the actions that I've suggested, because we need some immediate input of support to enable us just to get over that.
Okay, thank you. Thanks. And I think what's important to me, and it sort of encapsulates what Winston said, is really what's at the front of the plan, and that diagram about what we're trying to achieve, and we need to hold on to that, because staff have signed up to that, as well as signed up to it from our communities, and we don't lose that. Okay, I will come back and ask you to read the recommendations at the end, but I would like to move on to the finance section. And Hugh, can I ask you just to sort of draw out any highlights for that before I open it up for specific questions?
Of course, I'd like to start with an apology, because I appreciate that the COVID choices people are circulated very late, and that I think a previous version had come to the board seminar, but that's been updated somewhat since. So I don't monitor that very briefly. So an apology to start. And I guess I'd just like to echo what the Chief Executive has just said. This is a plan written at a very uncertain time and with a number of challenges. And in taking the judgment and the decisions that I've taken in working through the financial plan, this isn't a passive acceptance of a deteriorating forecast, but an active step to own the challenges, own the issues, and recognise, especially when it comes to those COVID choices and challenges that we've expressed, that this is now within the totality of the actions that we are taking as a board. I think that's a very important point to make. The second point, which somewhat echoes the Chief Executive as well, is that this is an assured forecast based on what we are currently seeing. That is, this is based on what we have current assurance on, that the actions that are being taken would lead to as a consequence. So in some ways, it is the counterfactual that we are now needing to work to address. And it's introduced those sticky COVID costs within our baseline. It's recognised the cost pressures that we're currently seeing, and it's also recognised that as we currently stand, the savings plans that we'd originally anticipated, savings challenge that we originally anticipated, and we don't have sufficient plan at this stage to be able to provide assurance that the financial position can change. The assumptions in there are fully in line with Welsh Government, so we have not anticipated any income over and above what we have agreed with Welsh Government before now to take. And the other point I just want to come on to in terms of COVID is that by recognising those costs now within our baseline, it is not an acceptance that these are recurrent costs that we will have. I think what it recognises is that there are a number of very complex challenges ahead, especially if we look to take those costs out, or recognise that those costs provide us with value opportunities elsewhere in the system. I think those are important to understand. And I wanted to make sure that we recognise that at the earliest possible stage. And I'm also not saying that this position won't improve. I very much hope by having this intervention, this challenge at this point in time, that we will make improvements on that 62 million forecast, and that will put us in a better position currently as we go into the next planning cycle. Recognise the points that Chief Executive has made around the need to triangulate the actions that are in the plan and the planning objectives, and understand what impact those will have both on our financial position and indeed on our performance. I wanted to share, just recap somewhat with the slide deck, just to, and I recognise we've had the opportunity in board seminar, so I won't labour the points too much, but just to go back over the planning timeline on the second slide. The original briefing back in December 2021, when the budget allocation was announced, we indicated that the underlying position this year could be in the order of 68.9 million. And that clearly has changed as time has moved on. But we have understood that there is a challenge for the system broadly, and a number of actions have been taken over the last few months to begin to mitigate and address that. What we've recognised, though, in slide 4 and slide 5, Chair, is a shift in twofold. Firstly, recognising that we had insufficient plans or insufficient assurance that around £17 million of our savings would be delivered. And secondly, recognising that there were cost pressures we were seeing in the system, the order of £4.5 million, and COVID costs that we recognised were now becoming part of the way in which we were delivering services of around 15.5 million. So that's resulted in a total shift in our financial position of 37 million. Now that, and slide 6, I think, outlined this clearly, is a gap between what is a historic trend of income growth as allocated by government to where we currently see our financial projections. As I say, this is very much a counterfactual that we clearly need to address, but it is not a pessimistic view, an overly pessimistic view. It is, on slide 7, you can see the continuation of our cost pressures and our costs as they are currently being experienced in the system. So there's no significant increase in that we're seeing in future months. The challenge for us is one of service change, service improvement and transformation that will address some of those cost pressures. And if I just come on to slide 9, and then I'll go into the COVID choices. And clearly there are consequences which I know the Chief Executive has outlined to a unsupported position of 62.5 million. And one of the significant ones for me is to make sure that we maintain cash flow, especially over the last few weeks of the year, to make sure that our staff get paid, to make sure that our suppliers and key partners are paid on a timely basis. And that's a significant concern, and we're working on mitigating plans to maintain cash flow over the last couple of weeks of the year if it happens to be. Chair, I may pause there before I go into the COVID choices section. For any questions?
Do you want to come in on this point?
General point just on the position, so I can wait to get into that.
Okay. Are there any questions on what Hugh has said so far before we move on to the COVID choices? No, happy to continue at the moment. Do you want? Yeah.
Because then probably better to take it all in the round.
Yes, okay, that's fine. Carry on, please.
Chair, on the COVID choices paper, the detail starts on page 7, but we are talking essentially about £15.5 million of costs that have been recognised as COVID pressures, but in assessing these with operational and clinical colleagues, it became apparent that these were now cost pressures that were embedded within the system somewhat. Chair, I'm happy to take these page by page or just recognise any questions in the round, but just to give you assurance over the process, we have gone through this through our clinical colleagues and Mandy's team in particular, through Jason Gantry and her work supporting the finance team and supporting our operational teams to reach a judgment on the nature of the costs that are being incurred and the consequences to us at this stage of switching off those costs. And I think in so doing, recognise that the consequences of doing that would be significant and need to have some work put in place to mitigate the impact of those. Or, as I say, we recognise those cost pressures within our baseline, recognise that the opportunities to shift value across the system has also increased. So, Chair, I may just pause there and allow questions on the detail, but I can go through each page.
Yeah, I think that's probably better on going through each page. So, do you want to come in now, Andrew?
I'll come in now because then it'll lead into the questions, I think. So it's just a couple of comments, if I may, Chair. So I just want to say from an operational perspective, and as Director of Operations and as probably a person with the highest, with Jill jointly, with the highest level of budget holder and budget responsibility in organization, I just want to be clear that we have made it very clear that we do not accept that 62 million is the forecast position for this organisation at the end of the year in terms of what we deliver, and that we have not authorised anybody to spend money to that degree, and we are expecting that everybody, in accordance with their accountability letters, provide us plans that pull their position back to their budgets that they've been allocated, and until they've got plans to do that, we will continue asking for options and actions that do so. So I just wanted to be clear that that's the message that we are giving within our operational, given the scale of the money that's spent within the operational part of the organisation. I just wanted to be clear before that we've made that message very clear, and that there were some sites last week in our last meeting that we need to work through and validate and assess, but there were some sites that there were options, ideas coming through that would start to reduce that position. But we've still got a long way to go on that, but we will continue to push that. The only other point I wanted to make just as well, because I think it's important, in moving some of these transitional costs into core, there are some examples whereby the movement impacts on our run rate and therefore our forecast, but actually, in doing so, it's actually putting in place and filling vacancies that we've held historically. So where we've moved people from fixed-term contracts into substantive posts, we've filled gaps that we previously had. So there is an element here as well of, I would expect to see we would start to get some benefit from now having in some places the workforce in place that we were budgeted for and established for, but never historically had the staffing position for. So that doesn't change the fact it affects the forecast position, but in terms of those services, it's not in itself a negative operational position to create. So I just want to make that it's not, that there's some benefit I think that we will get from some of this as well.
Yeah, well, that's a really important point. When you go through the list, you can certainly, a number of us can see where that's happened. Okay, thank you. I'm going to open it up for questions. Who would like to? Sorry, Winston.
Hugh, thanks very much for a very clear understanding of why our positions moved from where it was.
Speak up.
Thanks to you for a very clear understanding as to why our position moved from where it was to where it is now. And also thanks, Andrew, for saying that it's probably a bit more on the pessimistic side of things. And really understand that what you're saying is that we're filling the vacancies that we should have filled beforehand. On the consequences side, for me, it'd be useful to just link those to either our strategic objectives or to a particular improvement in our policy, safety or performance standards, because then it's really clear that where we're continuing our COVID-19 funding or whatever, it's going to have an impact on our performance metrics in a way in which, as a board, we can track that. Because I think it's really powerful paper. The question I've got really is because one of the uncertainties is whether or not the pandemic's going to resurge in the latter part of the year, and therefore by leaving these costs where they are, does that put us in a greater position to respond to that if the pandemic resurges, or if it does resurge, does that mean we will need to incur more costs? Because that's going to be a big factor to us as a health board.
Who wants to?
I might ask Andrew to come in, but my initial response, I think that's a really key question. I think it reflects the complexity of the environment we're in, because whether or not we, God forbid, get another variant that takes us down, we are going to have a really difficult winter for all sorts of reasons, including COVID, that we have to deal with. So at the moment, I think it's fair to say we haven't really emerged from the last winter, and actually part of our run rate issue now that is leading to this forecast is because we haven't been able to stand anything down that we would normally stand down at this time of year. So in some ways, we've got all of those things going, but I do want, in the paper I referred to coming back to board in September, to be really absolutely clear about those things, because if the money really is as serious as it is, we absolutely must own that. We may have to make some difficult decisions as a board about what we do around the trade-offs, front door in our hospitals against our financial position. That's the situation I think the NHS finds itself in, not just in West Wales. But I think going into the winter, what this does allow us, this does recognise a system that's already running hot. I think the question we just do not know is whether it's going to get hotter or continue at this rate, because it hasn't slowed down since. Andrew, did you want to add to that?
Yeah, so as you say, Steve, it's a hard and complex question to answer because the system is already running so hot, and we're at occupancy levels that would exceed where we would normally be at this time of year with surge capacity open and additional beds in place. So that in itself makes it challenging. I suppose the other factor I would just put in is that what we do see when COVID incidence increases is an impact on our staff, and therefore the ability for us to cover services, and we'll see in my operational update paper references to scenarios where we have to offer better enhanced pay rates over the course of since the last board meeting to provide on the safety grounds to be able to maintain and sustain some of the services that have been under pressure through this period. So we know that as COVID incidence increases, that will put pressure on our system, that will put pressure on our staff as things currently, our staffing systems currently stand, and inevitably in that there will be increased variable pay costs from having to maintain some of those services. It's hard to know how much further than that those costs might come through because, as you said, we're running so hot anyway. I don't want to say you can't run hotter because obviously you always can, but it feels like we're running very hot at the moment in terms of demand and pressure across the system.
Okay, thank you, Andrew. I'm going to bring in Anna.
Thanks, Chair. Andrew, if I can just explore with you a bit more the message out through your operational leadership hierarchy, and you mentioned accountability letters, and I think on the one hand that's very assuring for us as a board to hear that with everybody in the organisation is clear there is no back check. It's critical. I guess one of the risks in a very clear method on the money is that we lose the balance around the accountability that and that we know is immensely difficult for all of us to balance and all of us to account for. I'm wondering, for those people who don't have the privilege of sitting at the top of the organisation in the way that we do, how we are mitigating the risk that people feel unable to say that the measures they are needing to take to control the money have some very serious consequences on quality and safety, and how we support A, the conversation to happen, and B, that we are part of that journey with them, and that we are not simply passing our angst down into the organisation in a way that ultimately these patients will start with.
Thanks. So that I know Mandy might want to comment on that as well, but I'll just offer just from my perspective. So we've given a very clear message to our senior team who are our budget holders around their budgetary responsibilities and what we're expecting of them in terms of their contribution to managing the health board position towards the end of this year. We're very clear that we've asked for options and actions, and part of that is because with the process that we've set up around use of resource meetings, which are multi-executive attended and managed as part of those from a quality and safety perspective, we want to make sure that they are going into those meetings and attending those meetings with clear options and plans to discuss. We're not suggesting, and I don't think from the way our teams operate and the way we work with them, I don't think any of them would take a decision that they had any concerns, or they were feeling concerns from staff on the quality and safety without first wanting approval from us first anyway. And so we've got a couple of mechanisms for doing that. We've got our regular contacts with our teams and our more informal discussions where they'll be raising the things they're thinking about and testing whether that's something they should be putting forward or expressing their concerns about anything that they may have. But equally, through the more formal use of resource process that we've established, there is a plan executive team, if you like, or group meeting with them that can fully test all of those issues with them before they get the go ahead to make the decision potentially.
Thank you.
Yeah,
Do you want to say something?
Yes, if I may just come in. I think use of resources discussions is really important for us to focus on. We start from the lens of this is about delivering a quality, safe service. It's not about starting from the point of how much can we save, what's the money going to look like. So I'm very vocal in those meetings and attend the vast majority that I can certainly get to. So I think I just need to be really clear that it's not about the focus on what do we stop doing to save money. It's about how do we enhance the service in a way that drives the quality agenda, because as we know, if we spend money wisely on quality and safety, we actually drive down costs, waste and inefficiency. So that's the starting point. I think the mechanisms that we've put in place across the organisation around the Quality Safety Experience Directorate and team level meetings ensures that we are focusing on quality and safety throughout, in terms of how we are continually trying to improve our services, and all of the work that we're doing through either the EQUIP programme or any of the improvement work that we're doing is driving us to ensure that we're reviewing, streamlining pathways, taking out the inefficiencies, rather than continuing to perpetuate what could be driving costs. The DATEX system is one mechanism that enables our staff to openly report concerns around quality and safety, and I can assure you that that is being extremely well used. The walkarounds that we all do as well, both formal and informal, also provides a mechanism for our staff to be able to speak up very safely. Plus as well, we've got the mechanisms through Speak Up Safely as well. And then, of course, there's the position around the risk register discussions. And Andrew and I meet with every operational team on a very regular basis to walk through their directorate and service level risks, as well as the corporate team reviewing the corporate risk register. So I think areas where we are linking back to potential opportunities for saving or streamlining or improving the cost base of delivering that service is absolutely matched against the level of risk, the fragility of our services, and trying to make sure that we are all focused on quality and safety. So I hope that gives some assurance, but also a flavour of some of the work that we're doing.
Thank you, Andy. I've got a few people want to come in, but Andrew, did you just want to come back
It
quickly?
was just very quickly, which I hope will provide a bit more assurance as well. In those conversations, we're also having a discussion around, obviously at the moment you're projected to get to that point. There are opportunities within that possibly to do things very differently, but spend that money in a slightly different way to how we're just planning to spend it at the moment. That deliver a benefit as well, that brings the position back in line. So we're trying to also use the opportunity for them to enable them to be more creative and innovative as well, and perhaps not feel quite as constrained, but recognising that they can't do that if it's not going to pull the position back.
Very thank you, Chair. So just moving that back to Steve's earlier comments about trade-offs and different decisions that lie ahead for us, I think it's just worth us holding in mind that sometimes a poor service is worse than no service. And as a principle, we really should be very.
Yeah, thank you. Right. Do you want to come in now?
It's sort of on the same issue, that's all right. Do you mind if
Quickly, I mean, Paul Hugh's been waiting for ages.
It's just, I mean, Mandy's actually made a lot of my points for me, because I think it is one of the key worries I think we have as a team, and you've heard some of the things we're doing through our formal processes and all the things that Mandy's mentioned around some of the other ways in which we can arc around the system to keep our eyes and ears on the ground as board members. And I think that's really important, because it's worth saying, we know what happens in organisations that simply focus on a financial target, and those things are disastrous. So we all need to be open to that, and the way in which we're doing the more formal processes and the stuff wrapped around that, that's really important to the board. And really the only point I wanted to make in relation to your last part was, where there are decisions that we have to make to trade off, we have to make them here, and we have to do them consciously. And that's, I think, going to be that's what I want to start to get into from September, because that's our responsibility, not the responsibility of the state.
Okay, Hugh.
Chair, thank you. And I just wanted to come back to a point. Point that's been a couple of words that we mentioned: optimism and pessimism. I think what we have with the current forecast projection is a realistic projection, and I don't think that we are in disagreement on that, Andrew, to the point that you were making. I think mathematically we accept that that is the counterfactual at this point in time. I think the challenge that we have now collectively is making sure that the action we take erodes that counterfactual. I think that's something that we all recognise is unacceptable and something that we need to address. I do want to come back to the quality and safety issue, because I think we recognise that there are areas of expenditure that we are incurring now where they are certainly not providing good outcomes, and may well result in some harm along the way. And I think those areas that we can collectively work on and our areas of focus. But in having the approach that we've got through our use of resources, to be clear with the board that we are, as an executive, speaking with one voice. We are giving a very consistent message on living within our values, making sure that we are addressing our financial challenge, but doing that in a way that doesn't harm our patients or our communities. And I think that's a really important area to go on. And there are a number of checks and balances that are in place on that. In terms of quality, I know Mandy's reporting on quality is a check and balance on that, and something that I'm very mindful of. Indeed, improving together is a way of making sure that alignment is there. And then in terms of outcomes, value-based healthcare is there as a principle, and we are accelerating our rollout on capturing outcomes, because it's an important check and balance on the way in which we are taking decisions to allocate resources. I think those are important messages for the board to understand. We do have those mechanisms in place.
Did you want to just
just very quickly? So I'm conscious of the way we're set up as different people want us to see. So I just want to be clear that I confirm you said we're not disagreeing about the forecast. Okay. That's the position. What my comment is that professionally, as a team of senior operational managers, we are committed to improving that position.
Thank you. Right, I've got Phil, then I've got John, and then sorry, Winston, did you want to come in on?
No, well, I was going to make a different point, to be honest.
Okay, so Phil.
The conversation's moved on just a little bit, but just going back to a brief comment on Anna's point about the balance between the finance and the quality and safety, and also Winston, your point about clinical involvement. I mean, Mandy's speaker, even louder, crikey. Okay. Mandy's answered, I think, listed many of the things that I would have listed, and it's given a comprehensive answer. I think the other point I would make is that, you know, when we agreed our strategy, by agreeing that we needed a new system, we agreed that we had an unsustainable system and that there were consequences to that, and we've been very open about that. And I suppose that is shown on our risk register, and it's shown in our performance report. That doesn't mean there aren't lots of actions that we want to take to mitigate that. And I suppose the consequences of that are that I think the clinicians do have a very strong voice in this, because for two reasons, I would say. One is because of the way we set up programs, the major programs of work around unscheduled care, planned care, primary care, all of those have a really strong clinical voice built into them, and means that trade-offs inevitably have that really strong clinical voice within it. And we've got plans, you know, to continuously improve that and enhance that voice. I think the other thing is that working in this system, it means that clinicians are continuously flagging the challenges that are within the system to myself, to Andrew, to Mandy, and Alison and others. And I suppose, therefore, I do feel that we have a very strong clinical voice. Having said that, given the situation we find ourselves in, I think, you know, Andrew, Mandy, Steve and I are reflecting on how we improve that, because given some of the different choices that we might need to make in the next year, in future years.
Okay, thank you, Phil. Mr. Gammon.
Chair, most of my questions have been asked. But if I can just make one comment, I'm sure as a board we recognise that this is very complex, it's very challenging, and then as a board we're going to have to make very difficult choices, and the public need to be with us in that. I guess my challenge to the board would be is that we do that through the lens of the patient when we're making those choices.
Yeah.
And that when we talk about consequences, we've talked about impact, whether that be quality, safety, finance, etc., that we continually look at it in making those choices through the lens of the patient and what our public would want us to do on their behalf. We could own this plan, but in our delivery, the lens of the patient would be my challenge.
Thank you very much. That's absolutely recognised.
I think none of us have around this table to make decisions for affect patient safety, and with a pressure on our staff than they're already under. I think we do, however, have to also recognise the current position as said is unsustainable. And therefore, when we come to have a discussion about positions, what I think we need to see is not just the short-term choices that we make, but how we are going to be now moving from the position when we're in to a sustainable position. And how we move into that position as quickly as we possibly can. And that may involve us having to make not just short-term decisions to make the position this year, but improving the pace at which we undertake some of the strategic decisions that we put in order that we get to that position as soon as we possibly can. And instead we will identify what the financial gap might be between where we are and where we need to get to. If we can have discussions with our partners as to how that funding is going to be put in place to enable us to achieve that, then so much the better. But I think we need to understand where we're trying to get to, how quickly we can get to, and what the gap is between where we are and what we need to do.
Thank you for that. Can I bring Joe in? She's been waiting for ages, and I will come to you. Joe, I know.
No, I'll come in at the end.
Speak up, Joe.
No worries.
Yeah, acknowledging the very difficult position that we're in, it would be remiss from a population health perspective not to say that as a board and as a team, we've signed up to population health strategy, a long-term strategy. We're already starting to see the impacts of that. First area to hit the smoking cessation targets. We're taking a unique regional approach around our health away from the work with Swansea, and we know that chronic conditions that are driven by some behaviours are massively linked to wider terms of carbon deprivation, and we're making massive inroads with our health team to start to work on some of that. So it can't be captured in the finance report and the difficulties that we're in right now. There's so much work going under the surface that actually will reduce our service use, or with the eye of faith, we will be working towards reducing our service use in the future, and hopefully we'll see the benefits then.
No, I think that's really important that we don't lose sight of those when we're setting out the whole position in relation to where we are at the moment. Winston, you wanted to come in?
Yes, again, because positions on the sensible of our government and leads us to, I think, take some hard choices. I was just thinking about it leads us to actually be more limited, to actually be bold at this stage. Because we can focus on the use of resources about trade-offs between safety, quality, and performance. But equally, I think we can go, what are the innovations that we can put forward and invest in to demonstrate that we're at the forefront and actually attract some funding to support us. So I'm just quoting from things that we're doing in the plan, just to illustrate the point. So, concept of the virtual hospital, I think that's innovative. And we've got a digital strategy that I think is one of the best I've seen, for example, and we can promote some of that. Your point about some of the population health things where we're at the forefront, I think it's important for us as a health board, as well as acknowledging the difficult financial position, but also saying where we're putting those resources to, what are the outcomes, because I think that's going to be important in securing support within the health board partners, but also external to the health board as well.
That's a very good point, and yeah, it is that whole picture rather than just focus on. I want to bring Steve in to close this, but Hugh, did you want to?
Only very brief response, just to confirm that that's why we've called the way in which we're working through this our use of resources kind of process, because recognising that money is only one part, people is another significant part, technology and data, and of course the use of resources needs to drive an outcome. And so that's the very nature of the process that we've set.
Okay, thank you. Steve, can I come to you with what you're saying? Can you then repeat the recommendations,
which I've
please?
slightly tweaked in the discussion, not my mind. I don't notice it, but yeah, I think just a couple of things I wanted to pick up there around Winston's comment, Paul's, and Hugh's. I think what we've got in the way of this plan, these planning objectives, are really bold. There are a lot of things in here which are going to provide benefit for our local population, and indeed therefore have benefits for us in terms of quality, safety, experience and money over the long term. I think Paul's point is the right challenge. It's we need to be clear about what we're doing in the short term, the very short term. I think in that regard, we've got two broad things going on. We have the use of resources groups going on with directorates, which, if I can express it in this way, is perhaps more in the traditional what can we do to pull the position back kind of discussion, with all of the caveats and observations that Andrew and others have made. But also what we have in the plan will have immediate impact on our system. So the work particularly around urgent and emergency care, that's a long-term shift in our system, but we're doing it now, which is why I said kind of at the beginning, it feels like we've got all the right actions in all the different layers, from population health through to reconfiguring the system now through to the programme business case. What we haven't been able to do is express what does that mean this year, next year and the year after. So our target operating model work, and I think it's on page 12 of the report, sort of sets out the planning objectives that are all contributing to that. For me, that sets out our journey, which started actually months ago, on how we're going to get this system to the point where it's starting to exhibit the behaviours that we want, as we've envisaged in the Healthier Moving West Wales strategy. I think the bit we do need to pick up from your comment and from Winston's is we also need, as part of this work, to start to express how we get back on the roadmap that we set out last year, because this has knocked us off course. But I'm optimistic through this work that we will be able to show real progress back to that roadmap and get it in place in time for the programme business case to come to sort of full fruition with the final business case over the next few years. So I think we've got a lot of work to do, both to describe the in-year, but also to describe the longer term from what we're doing. But that's really why the actions are, as I've set them out, to give us some immediate additional support to enable us to do that.
Okay, thank you, Steve. Do you want to just outline the recommendations so that we're all very clear what we're seeking approval of?
So I'll take it slowly. So the board is asked to approve the planning objectives and supporting actions as set out in the plan, but requires a further update in September regarding the translation of these objectives into the key deliverables of quality and safety, performance and finance. This paper should also set out the choices that can be made between these three elements for discussion and agreement. And we will do that through the lens of our patients and the public. Furthermore, I'd ask the board to approve the recommendation that this update is subject to further scrutiny at the relevant committees before we get to board, so there was an opportunity to talk in detail about it before it arrives. Which I think we'll start with SRC on the 22nd of August.
And do you want to, so are people happy to approve that recommendation? Okay.
It helps members now to
Okay, do you want to cover this about the additional actions?
So yeah, just for the record, so the additional actions we'll take as an executive team is to write a further letter tomorrow to Welsh Government in light of today's discussion. Thank you for all of that. And we're going to ask for three things from them, and an additional thing we will do internally. So the first is for the financial delivery unit to provide additional immediate support to help us to translate the planning objectives we've got into the impact to work alongside our finance team. The second is to invite the delivery unit and Improvement Cymru to review our planning objectives to ensure that we have all of the right ambitions in place and underpinning actions, and that there's nothing further that they think we should or could be doing in order to address the position. Thirdly, we seek to establish a monthly meeting between the executive team and Welsh Government colleagues for them to overview and scrutinise and challenge our progress on those three issues of quality, safety, performance and finance. And then as an internal action, in addition to that, with the permission of the chair, we will re-establish the weekly IM meetings that the chair and I will attend so that we can keep you appraised of progress in the same way as we did during the COVID.
Great, thank you very much. So we've approved the recommendation, we note the additional actions, and I will feedback when the chair's back next week to in terms of re-establishing those weekly briefing meetings for us as long as we deem to be appropriate. Okay, thank you. Can I thank everybody for that conversation? Thank you to Steve and the executive team for all the work you've done on this, and also for setting it out so clearly for us today in addition to the papers, and also thank you for the discussion and how we've had that very rounded position, which is where we're coming from really as an organisation, not only to focus on the money, we recognise the importance, but actually where it sits in the context of all our plans. So thank you. I'm going to move us on. We will be having a break this morning, but not just yet. So, and there's a reason for that. So I'm going to move us on to 3.4. Hugh.
Yeah, I think in many ways the finance report, we've spoken through the key issues within the finance report. There was just a couple of things I wanted to highlight forward, and in some ways it's the table on the bottom of page 2 there. In a way, the RAG rating is in itself misleading. It is against the forecast, not against delivery of our statutory target, and clearly that would be a very different assessment. So that impact on revenue and savings. Cash, I've outlined that if our current trajectory continues, then our management of cash will be challenged in those last 2 weeks of the year in particular. and we are working on what that mitigation strategy could look like, and I bring that back to board through the Sustainable Resources Committee at an appropriate juncture. And of course, that would then have a consequential impact on possibly non-NHS and public sector payment practice code England paying quite some property. That I don't want that to be a point of over concern at this point. That is a plan that we need to set out and bring back to the board for consideration in the round. And the other point, just to highlight probably down on page 9, through all of our drivers of spend, the most significant one where that shows itself clearly is within pay and within our use of agency in particular. And while you can see there that agency nursing has been on somewhat of a reducing trajectory, I wouldn't want the board to read into that any significant messages. I think that is purely a supply constraint that is in the market at this point, as staff are using their leave and agency staff are themselves using their leave or are unable to work because of sickness or other reasons. So I wouldn't want anyone to be reading into that any particular trend at this stage. And I'm conscious that that is a key driver of our financial deficit. So Chair, with that, I think the rest of the discussion, we've had a rounded discussion on already. Questions.
Okay, thank you very much. Any specific questions? I think we've had a good discussion on the finance. Okay, so thank you. The recommendation there is to note and discuss, which we have done. So thank you very much. I'm going to move us on to 3.5, financial well-being. Lisa.
Thank you. So the paper that you have in front of you today is setting out a series of actions that we're taking to support our staff through what are very difficult financial times. You can see in the report that we have a happy benefits app. So for any members of the board that aren't a member, you can log in, it is free. And there are many benefits that people can obtain from their weekly grocery shops through to holidays, through to insurance. It's a whole raft of benefits for staff. We are holding wellbeing seminars for our workforce, so they are being done via our Teams system, and there are more being planned at the moment. And we also have a range of salary sacrifice schemes so that individuals can take advantage of purchasing goods using the taxable benefits that can be gained through that process. There's an internal action plan that we've attached for your information, where members of the workforce experience team are driving a set of things within the organisation to support our staff, which will include things like reducing food waste in our canteen. So how can we make it possible for staff who are facing difficulty to be able to obtain meals at the end of their day? Flexible working and how that supports individuals not to have to drive into work every single day. How can we maximise the benefits of that? We have top tips, so from people like dietitians, how to make healthy, nutritious meals on a budget, how to better manage elements of your finances. We are looking at a car sharing portal, so again, individuals who live in similar locations would be able to take advantage of sharing that lift into work. And then one of the other things that you will have seen more nationally is period poverty, and how we can support individuals in very discreet ways to be able to manage their situation. But as well as just wanting to support our staff, I think it's really important to just point out to you, well, there are business benefits to this. If people are struggling mentally, psychologically, we could lead to increased absenteeism from the workplace. Staff engagement, some people just may find it difficult to drive into work, and if they can't afford to put fuel in their vehicle, they may have another excuse as to why they can't come into work. They may be distracted with what's going on in their mind. It will have an impact on retention, because some people may have to make choices about where they work and what they do. But also it is a really good attraction strategy as well, in that we do care about our workforce and we want to do all we can to support them. There are some challenges in this, and I think one of the things that we've learned through trying to introduce this period of work, this piece of work, is we don't want to duplicate or create any tensions with any good things that are already going on in our local communities. So one example of that is that we had thought about how could we create an arrangement whereby school uniforms could be made available for individuals. We are aware that schools do that, so we don't want to step on any good initiatives that are taking place. So the team are working really closely with our county councils and with our staff and with our trade union reps around what are the right things for us to engage with and do. So that, in a nutshell, is what's in the report. We were hoping to start the trial period of the reducing food waste a couple of weeks ago. That was delayed slightly, but it's due to start now, and we're very grateful to everybody in the organisation that's helping to pull this together. So I'm happy to take any questions.
Okay, thank you, Lisa. I think we all recognise the situation at the moment, and I think to see the range of actions which have been put in place is very welcome. I will open it up to questions.
Chair, thank you very much. Lisa, thank you and your team for this paper. We know that staff are facing many significant financial challenges, particularly when it comes to the action plan, as noted, and some of the actions that are put in place. My question is to what extent are we aware that this is impacting on turnover, particularly amongst lower bands?
At the moment, we don't have any evidence that it is impacting upon turnover. I think what we are seeing is that it is potentially having an impact. It's potentially having an impact on recruitment, because if you can take a job that you can walk to, people are going to do that at the same rate of pay than they are to come and choose to work for us. So we're seeing it there. At the minute, we haven't seen the impact on retention.
Winston.
Thank you, Lisa, for a really good paper on how to support a number of initiatives in relation to the cost of living crisis. I know that we are working with partner organisations, and I know that Aston and Barclays provides contribution in terms of our advertising for them in this paper as well. I just wanted to just question really two things. First of all, how are our line managers going to translate these range of initiatives to staff? Are we proposing to do that? Do we have a kind of checklist approach or something like that? I think that's going to be important for them to talk directly to those staff on the lower end. Second thing also, what links are there with this and the foundation economy work, in a sense? And the reason why I'm talking about that is that obviously people have got healthy communities, and those communities are better able to support people who are at the lower end of the remuneration scale.
Okay, so first of all, the promotion of individuals within the paper is unintentional, and there are other supermarkets and other chains that are available, and any organisation who is on a happy benefits app is being promoted. So that's the first part. The part then, second part.
We set up the line managers.
Line managers, okay. So our OD relationship managers and the workforce experience team are engaging with our staff and our line managers. And actually this week there is a staff benefits roadshow that's taking place. They were in Withybush Hospital yesterday. So they are in the dining rooms speaking to staff in areas to talk to them about all of these benefits that are available. We have our Speaking in Confidence platform as well. So for any individuals who are facing hardship, they can very confidentially talk to us about that, and we can put support mechanisms in place. That's the second part. The third part around foundational economy is absolutely centre to all of that. It links in absolutely with all of our plans around how do we support individuals in our communities to have meaningful employment. And part of the work that Hugh and myself are working on is around how can we better enhance our recruitment offering as well, because actually if you don't have a car, how can you come to work? So what can we do to support individuals in driving lessons, sitting car tests? If you want to pass your driving test, the waiting list now is December, I'm told. So it's all of the things with our local communities that we can do to support individuals to gain meaningful employment and to keep meaningful employment, and this is part of the we keep them in employment.
Thank you. I've got a few people want to come in. Questions? Paul.
To what extent have we looked at the transport plans? Support the staff and the paper initiative. This is trust and whether there's
we're in early discussions with the charities team to see whether there is anything that we can do. So I'm not sure where that may go yet, but certainly I think we will be involved, and our teams are liaising at the moment. And we have done a paper around the Capital Trust to see what we can do, but that is for a specific staff group.
Okay, thank you. Dalith.
Thank you. Paul, in answer to that, I'm pursuing the issue about childhood funds, making sure there is equity, and this is the issue for me, is equity for our staff groups. You mentioned Low Children's Hospital, but we have a number of our lower paid staff working in our communities. What are the plans to actually assist those members of staff to access? Because as we know, we live in a rural area, and you mentioned cars. We have got a public transport infrastructure as well. So how are we working with our local authority partners to really think about ways of actually assisting our staff, especially in communities?
We have a regional workforce board, which is each of our county council partners and myself. And then obviously other representatives within the health board. And part of that is how we all work together to support our communities. Our first joint apprenticeship programme is an absolute key one of those, again linked in with foundational economy. So we are very much linked. The wellbeing roadshows will be more than just the hospital sites, and they're making a difference programme. So if you remember our customer care programme, which is for every member of staff, one part of that is around all of these benefits as well. So every member of staff that attends is talked to about the happier, how we're supporting staff with financial issues. So it is very key to them, and that programme is running now.
Okay, thank you. And you.
Thanks, Chair. With the plan which you've listed, obviously food is a key part, as is the well-being. We've heard about the relation to the potential for the foundation economy as well, and for how that is seen to be intrinsic in supporting our local kind of society in terms of socioeconomic opportunities. It might be as one further kind of solution. Obviously, we talk about food banks, but for those kind of staff who may not be as vulnerable financially, to support their financial well-being and opportunities, many of the staff work shift, so they won't have access to, you know, the kind of farm shops where we're seeing local producers with local produce in local supply chains being readily available. So there is a project which is Welsh Government funded, which does cover the Hywel footprint, which is the Wales Community Food Distribution Project, which I have to kind of declare an interest in. It's one of the projects which we as Planet are kind of supporting with partners, but it already has set up hubs in Lampeter, Pembroke, Tenby. Both is coming on stream, and that allows local producers to work with the local population on a fixed basis once a week to put their orders in and to collect that fresh produce, which perhaps they wouldn't have access to routinely because of work commitments and hours that they work and so forth. And so far, it's creating real kind of socioeconomic benefits, well-being benefits. I think if perhaps we looked at the opportunities of where we have our kind of buildings across the 3 counties to help our staff have access to those local supply chains more readily available, where they don't currently because of shift patterns. I think that may be something which helps well-being generally, and we'd be more than happy to kind of work with and support.
Thank you. Okay, we'll take, so we can make a note of action to take that forward. Thank you. That's really important. It's about how we connect to everything up. Okay, so thank you, Lisa, for you and the team for all the work we're doing in this area. Thank you everybody for the questions. And you have the recommendations there for this paper. Okay. Right, well, I have failed in getting us through this section, but I think it's important we do take a break. So I am going to break at the moment, and hopefully move us through the next part a little bit more quickly. So if we can be back at 11:50. Thank you. And coffee's outside. So I was trying to get us through, Jill.
Right, coffee's outside, back at 10 to. Just so we have that whole discussion. Yes, no, Okay, welcome back, everybody. We'll now continue with the agenda. Yes, okay, I'm just checking technically if we're back. Thank you. So we're on, I do need to move us through as swiftly on the rest of the agenda. So 3.6, we have, I think, Paul Williams on the call. I'm going to just ask the Chief Exec, do you want to make a brief introduction?
Right, and I should just recognise Paul got COVID yesterday, so he may have to go on mute if he does start to cough.
I know the feeling, Paul. So I hope you feel better soon.
I'm going to propose, and hopefully Paul will be okay with this, because obviously Lee is absent today. That we just take questions on this paper, recognising that actually the main substantive items, particularly around the land identification process, are coming to a special board meeting next week. So rather than talk through the paper, which I think is fairly clear and quite concise, because of the fact we have another board meeting, we just take any questions.
Yeah, okay, thank you. So any questions that on this paper? Okay, no, I can't see any. So Paul, it was good to see you. I hope you make a full recovery soon. Thank you for getting yourself together to dial in today, and I'm sure there will be a lot more discussion next week at the extra board meeting.
Thank you very much indeed. I'll leave you to it. Thank you.
Thank you. Okay, thank you. So we will move on to 3.7, which is the Section 33 agreement.
Yes, thank you, Chair. This is a fairly straightforward item, hopefully, and something that board members will be familiar with from previous iterations. Board members will note that the current or the previous agreement was in place up until March 2022, and there was a Chair's action taken to sign that off in August 2021. This revised or refreshed agreement is now a 3-year agreement that is proposed. And the other factor that I would want board members to note is that the share in the total of 547,000 split between the local authority and the health board has changed. And the additional or the increase in the health board component of this reflects our greater usage actually of the equipment that has been needed to support individuals within our community. So it definitely reflects our strategy actually in terms of caring for individuals at home, and the increased usage that we've made from that equipment store now reflects the agreement that is to be recommended to the board in place for a 3-year period that will take us up to March 2025. So I'm recommending that to the board today, and the agreement is attached for board members' reference.
Thank you very much. Are there any questions on the document or on the covering paper? No. Okay, so are we happy as a board to approve the agreement for 3 years? Yes. Thank you. Thank you very much, Jen. Okay, so we move now into section 4. First paper there is 4.1, the operational update. That's over to you, Andrew, please.
Thank you, Chair. So this is the second iteration of the outstanding item in terms of an operational update to the board. So as always, we're very open, Jen and myself, to any feedback on what would help make this report more helpful and useful to board members as we develop the report over the coming board meetings. And what we are trying to do is effectively 2 things to this report. One is to provide a update on the actions we're taking to make progress against the identified board priorities in our for this year, in particular those that relate to the operational services around mental health, transforming urgent emergency care, planned care recovery, integrated communities, and the links then into money and finance from an operational perspective, and workforce, sorry, not money and finance, duplicated that, workforce and finance. In doing so, it's not, and then provide a bit of an update in terms of some of the system pressure and things that are going on in the system in between meetings. It is not meant to be, I just want to be clear, it's not meant to be an alternative version of the IPAR that we get later on. It's not trying to deal with those performance issues in that way. but it will use on and call on some of our management data that we're using to track progress with the delivery of those board priorities. If I just go through a few things then in opening up, and I'll see if Jill's got anything to add, and then we can go to questions. I think in terms of COVID, since the last report, we did see a resurgence in the number of COVID incidents in the community, and therefore the impact of COVID on our system and our hospitals. At the time of writing the report, you'll see that there were 125 COVID patients, positive patients within our hospital system in beds. As of this morning and from the latest update, that's reduced to 58. So it does feel like that there, as was being forecast about through that period, there was a short and relatively sharp peak in that wave of COVID, and would expect to see, with some bumps in the road, that number will continue to reduce now over the coming weeks. However, as with every increase in COVID, that does have put added pressure on the operational system, and particularly the urgent emergency care system. And linked to that, we've seen us continue to operate at significantly high levels of escalation in terms of emergency pressures, which I recognise translates in terms of our public and patients and our staff into a system whereby there's delayed access, poor experience, and it's difficult for staff and pressured for staff. So I want to obviously apologise sincerely for those delays that people are experiencing and continue to experience accessing our systems, and thank the staff for everything they're doing in very challenged circumstances still. That COVID impact has had an impact on our staffing, ability to staff services and staffing availability, as well as our bed capacity. We've seen wards and beds closed during that time, which all has contributed to challenges in the urgent emergency care system generally. And as I outlined earlier, there have been 2 occasions since the last board meeting where we've had to adopt an enhanced pay arrangement to cover 2 weekends, one in June and one at the beginning of July, in order to make sure we could maintain safety across the system and manage patient flow and demand on the service. And the paper does ask the board, that was obviously approved through the appropriate executive and organisational governance process, but it does within this paper ask the board to retrospectively approve the application of those rates for those 2 weekends. A key part, as we've talked about, is the Transforming Urgent Emergency Care programme, and we successfully launched that programme, which was entitled Frailty Matters, on the 16th of June. And I think I know a number of members are at that event, but there was a lot of energy and quite a good buzz in the room, and a lot of interest from Welsh Government in what we were doing within that programme and our plan for transforming urgent emergency care. I think what's really not unique but important about that programme is, whilst it does set the scene for how we will transform the system to be more sustainable in the future, it also ties directly into the immediate actions we are taking here and now to improve the position within the urgent emergency care system. And there are, whilst the pressure still remains, there are some green shoots from some of the actions we are taking in that space that are starting to look like they will have an impact. The key will be seeing them consistently impact in the later performance report that we get to, but things that we're trying around advanced paramedic practitioners reviewing the stack linked into our intermediate care MDT to redirect patients and avoid conveyances, direct paramedic referral into our same-day emergency care services, the functioning of our same-day emergency care services themselves, all seem to be showing signs of having impact. So we've seen those from the APP service, we've seen a 67% reduction in conveyances from the cases they've reviewed. We're seeing 30% of our medical take go through our SDEC services, and around 70 to 80% of those patients being assessed through that service having their admission avoided. So there are some positive shoots that give optimism. Whilst we've had some very bad days over the last couple of months since the last board. We've also had some very good days, and those good days are important to recognise and make note of, because they give the staff on the ground a sense of hope that we can actually, through the actions we're taking, get the system back to a place that would possibly resemble more like we would expect it to have been 2 or 3 years ago before COVID. In terms of the planned care recovery plan, we continue to progress with our implementation of that. The one and broadly on track with our cohort reductions that we would expect to see. And as I said earlier, we'll be reviewing that in detail with the National Director for Planned Care Recovery later on this afternoon. But I did want to pull out that since the board, we went through the plan and submissions in great detail at the board seminar session in June. I did want to call out that since the board seminar session in June, as we were getting ready to, well, basically inspect and assess the modular unit in Prince Philip ready for handover and operationalisation in August, there was an issue identified with the ventilation system there that's required some urgent remedial work to address. We're now working to, and the report identifies that operationalisation has now been delayed until September as a result of that work, and that has been reported through the capital subcommittee, because it's all happened since since that seminar. So in terms of the things I wanted to pull out, I'm happy to pause there. There are papers, as you know, on community paediatrics and an update on mental health and then disabilities as well coming to the board as the next items, but I'll just check if there's anything Jill wanted to add.
Yeah, thank you. Very briefly, I mean, the paper does emphasise that there still continues to be a level of pressure that we're seeing within our primary care contractors. As of 2 weeks ago, we were still reporting a higher percentage of sickness amongst GPs than the average across Wales, and we were still seeing some closures of our community pharmacies in terms of COVID as well. That's important in terms of access. So again, as Andrew, I'd want to apologise to any patients who are finding difficulty in terms of accessing their primary care services. It's important that we optimise the opportunities within primary care through our community pharmacies, general practice, etc., as far as possible. And I know that there's considered political interest actually in terms of ensuring that we do provide good access for our communities. And the Minister has emphasised the importance of ensuring that we do have the ability to provide the general medical services and other services to our communities in that regard. So, you know, where we are seeing sustainability issues within our primary care contractors, we're supporting those. And we're also addressing any issues around development plans with 1 or 2 practices in particular, where there appears to be a particular issue for them in terms of their own capacity and the ability to meet the demand that we're seeing. And we're seeing a level of probably about 25% increase in demand across our primary care system. So I do want to emphasise that at the point at which the system is still constrained. Equally, it's important because as part of the urgent and emergency care programme that Andrew talked about, it's been recognised that we couldn't operate just one single urgent primary care centre across the health board. That's spread through our independent contractors, and the majority of our independent contractors are also providing some of that urgent primary care access. So again, we want to make sure that system is as functional as possible. The other element that this brings out is our care homes and our communities, and we note again that within our community nursing teams, even in the last fortnight, we've seen particular constraints, particularly around Llanelli and Carmarthenshire in terms of that capacity. And the paper brings out as well the issues that still are operating within our care home capacity. And one thing that I've talked about to Welsh Government is some of the sort of national messaging, because again, while we work to support our care home sector jointly with our local authorities, we're still seeing a number of beds that are vacant but which are not available to us to access, and that's really important in terms of flow through our system and getting the impact that we want to see around our planned care recovery as well. So those are probably just the key points I would bring out. We are getting a paper later on around vaccinations, but this paper does again highlight the fact that we will primarily be supporting a primary care delivered vaccination programme, but that's again subject to some of the constraints that we've got possibly around capacity within our system. So thank you, Chair.
Thank you. I've got Darren who wants to come in.
Thank you, Chair. It's in regards to our ambulance services, especially within our rural communities. I'm getting increasing concerns voiced to me by members of the public that they cannot access emergency ambulance transport, especially with CVAs. And on a personal note, I did have to administer first aid in Aberaeron a few weeks ago, and the patient had to be transferred by a relative's car to Gangwili. I understand that there is a meeting this afternoon with WAST, but I think we really need to be cognizant of the issues for especially our rural and our tourist communities. Bearing in mind we have the Eisteddfod in Tregaron, in a very rural area of Ceredigion. There is going to be an influx again of our public, and with that a risk of accidents or other issues. So can I take the opportunity to actually raise this issue here as in a public board, that increasingly we have members of our communities really raising concerns about WAST and our provision. I don't know, Andrew, obviously this needs to be fed back.
Are you going to ask Andrew to answer that? But could you also reference the paper which is going to WASP board, which has been circulated to board members in terms of the overall performance issues?
Yes, I think it's important to recognise that the challenges that are being experienced in terms of ambulance performance and response in the community is effectively a direct symptom of the pressure the overall unscheduled and urgent mental care system is under. It's not purely, and I think as partners within that, as partners within the health and social care system, we all have a contribution and responsibility to make to supporting that, the improvement of that position. We know that from a health board perspective, one of the things that will be cited as contributing to that are the delays that we see at our front doors in terms of ambulance offload at the current time, and the fact that that ties up vehicles and their ability to go and respond to calls in the community in a timely fashion. We have on that front established with WAST a joint operational delivery group to take forward an improvement plan directly focused on impacting on that handover position. And in a recent meeting last week with the Chief Ambulance Services Commissioner and my counterpart in WAST, there was positive feedback in terms of the actions we were taking, the impact they were starting to show, the potential impact they were starting to show they could have, and a real desire to see where that then takes us in terms of our performance. We did see in June an improvement in our ambulance handover delay position. We've had a difficult July for a number of reasons, as I've outlined. In particular in relation to the capacity we've had, and because if we haven't got capacity in both of the system, it always ends up manifesting itself in delays around the front door. So we are working very closely with WAST on that plan. There are a number, the advanced paramedic practitioner, the direct referral to SDEC are a couple of the more significant actions that are having an impact, and that we have been certainly the SDEC referral, and there's another action around local authorities paramedic having access to local authority brokerage lines to be able to test whether patients have packages of care in place to help make it, because it's been reported that in some circumstances that might influence a decision to convey as opposed to maintain a patient in their own home. There are a couple of things like that whereby we were the first health board to start piloting those schemes. So there's a lot of interest in what impact they have. There is a fragility in the system and the improvement, and we'll have seen a difficult July, and that's partly due to COVID and key individuals being off. So there's some work we're doing now to work out where those green shoots are and where we're seeing impact. We have in place robust services to deliver that. The paper going to WASP board today is around, again, is emphasising the significant risk in the system and the harm that is potentially and actually occurring to members of the population from the delayed response times from the ambulance service, and comments on some of the factors that are driving that across the whole system. There are within that, it does talk about some specific actions around strengthening the immediate red release policy, which is a situation whereby when there are ambulances held, if there is a red call made in the community and it's been extended to include amber 1 call, so in the instance of the CVA that you referenced as a personal reference, if there was not a vehicle to respond and we had vehicles outside one of our hospitals, we would receive a call and be expected to release an ambulance immediately to go and respond to that call. And there's a process being put in place to investigate and review an action plan around that. There are some specific expectations as well around reduction in ambulance handover delays in terms of hours lost, but also in terms of starting to implement a zero tolerance to delays over 4 hours as well, and in the hope that will start. 4 hours in my view is still too long and is not what we should be ultimately aspiring to, but in terms of driving change in the system from where we are at the moment, they're seen as milestones for this year to really work towards ahead of the winter.
Okay, thank you very much.
Thank you, Chair. A couple of questions on specific services. The long COVID service, was we seeing a reduction in people being admitted specifically for COVID treatment? Are we seeing any reductions in the number of people being diagnosed with long COVID as a result of a vaccination program and so on, or is that service carrying on? And the second question on a different area is, it's really pleasing to see the 111 service being developed for mental health. And we're a month in now. I'm just wondering, is there any update on how that service is being received by the patients and clients?
So if I do that in reverse order, so in terms of mental health, yes, we get. I know we've got a mental health paper, so there may be a moment where Liz will have some up-to-date data as well in terms of some of the numbers accessing that service. But certainly initial feedback has been really positive, both from patients and from staff within the system around the support that is providing. And I know nationally they were really pleased to see that established, because that was we've been piloting that on behalf of Wales. So there's a lot of interest in that being successful, but the early feedback is positive. And as I say, we can ask Liz to maybe expand on that when she helps cover the item on mental health. In terms of long COVID, I mean, I think Alison may want to come in on this as well, but I think we're not seeing. I don't think we've seen, for all of the publicity, I don't think we've seen the level of activity perhaps come through that service that we maybe anticipated when we were setting up the pathway and the model. We are seeing, as you'll see from the report, we are seeing a steady trickle of patients being referred through into that service. And as you know, with COVID continuing and possibly with issues being identified with the different waves, I would imagine we'll continue to see a trickle. I think it's fair to say we've not seen the wave of demand that we perhaps maybe anticipated 18 months ago when the first wave had hit and we were looking to establish a pathway for long COVID.
Do you want to come in briefly?
I would agree with Andrew if I can answer that. That's probably quite a difficult question to answer. I mean, we could certainly provide you figures for referral rates over time, but I'm not sure that will answer the question, because I think some of the referrals that are coming through may be delayed, because this largely depends on a member of the public speaking to the GP making a referral into the system. But we'll certainly share that information, but I'm not sure that will answer the question. I mean, certainly what we're doing with the long COVID service is looking at how we build on that to provide that level of care to people with similar symptoms but for other reasons. But I think picking up on COVID as well, and just linking back to something that is in the report that Andrew mentioned earlier, as well as the numbers of patients that we're seeing in the hospitals reduce. The Public Health Wales data is showing over the last couple of weeks a decline in COVID rate of 100,000. I'm giving that with a health warning, because most of that testing now relies on individuals uploading their results. But I think we can take it that probably COVID in the population is at a higher level than is being recorded, but it's definitely on that downward turn.
All right, thank you. Okay, thank you for that. I'm going to move us on, and we have the recommendations.
here. Sorry.
No, it's
Oh,
asking all that.
oh, okay, sorry. So we're asked to receive the update and report and retrospectively approve those enhanced pay rates. Are we content to do that? Okay, thank you. Next item is community paediatrics. Andrew, on again.
Sorry.
Sorry. So actually you could leave the microphone.
Sorry.
Yeah, there was a flag. Right. Andrew.
Okay, so
You've read it, so to you.
yeah, thank you, Chair. So I mean, the paper I think is relatively self-explanatory, and we're bringing this here today to public board, having had a detailed deep dive discussion, as Anna articulated earlier, as chair of the Quality, Safety and Experience Committee since the last board meeting. I think the key things for me to pick out are obviously we're responding to concerns that have been raised by some of our clinical team and our consultant community paediatric team around access to services and delays in access for children and young people accessing their outpatient services and for follow-up appointments. In response to that, and after initial assessment of the position, I've established a task and finish group chaired by the Director of Secondary Care, who is taking the community paediatric outpatient service through the same capacity and demand process and action planning process that we would apply to our other normal outpatient type services. Community paediatrics is not a service that is nationally reportable within the definitions of the waiting times definitions as reported in the performance report. So one of the actions we will be taking as we develop this is making sure that through our regular performance reporting to the board, we provide a position on where community paediatrics is against that. The key issues within that are, at the moment, in terms of the overall waiting list, the overall waiting list has grown marginally over the course of the 2 years during the pandemic. We've seen waiting lists generally increase quite significantly over the pandemic, but in terms of new patients referred in, the overall number is relatively stable or not seen a significant increase. The challenge within that, though, is that the number of patients waiting longer in time bands through that service has increased, and that's where we're wanting to make sure we put in some urgent action to pull those back as quickly as we can. We did have pre-COVID, the initial assessment has proven, we did have patients waiting similar lengths of time to what they are now, just not in the number that they are now. One of the key actions and aspects that the clinical team are concerned about is making sure we communicate with the families and the children that are delayed, and that's an action that is being progressed. In some regards, the communication out is in some ways the easy part of that. What we wanted to make sure, though, was in writing to everybody and contacting them to inform them of the position. We also gave them a means and contact point to come back to should they have any concerns or queries or want to discuss any aspect, whilst they of alternatives they could seek, or what they can do in the interim, or any anxieties they've got with the team. So there is a conversation happening, might even be as we speak, but certainly over the next few days, with the team leading the waiting list project and the communication with patient work we've been doing through that, to see how we can tie that bit of the communication element in with that wider waiting list work, so that we've got a proper contact route for that, or single point of contact for that. So I'll pause there, I think.
Any questions that anyone wants to raise?
Yeah, thanks for the
Just speak up, Lena.
sorry. I was wondering, there are other initiatives going on in the health board, such as family-based healthcare, which seems to primarily at the moment be targeted at secondary care and improving service there. Just wondering whether we looked at whether the principles of value-based healthcare can be used in situations such as community paediatrics.
Thank you for the question. I don't think we have specifically, but I think it's a really good suggestion and one we'll take back to the team as a way of looking at how we remodel the service to reduce the waiting times.
Yeah, thanks. Two things, Andrew. In relation to the demand and capacity tool that's referenced, could you indicate what that's telling us at the moment as to what the gap may be, if there is a gap? In relation to the PBIS service, what is the 31st of August the anticipated commencement date for that service? If not, what is the date? In relation to WPAS, is that now working as envisaged and optimally?
Okay, so there's 3 questions. So in terms of the first point there, so in terms of early period, the demand and capacity work is interesting because when we look at it, if you look at it in pure numbers, it doesn't necessarily on paper look like it's simply a capacity issue. So follow-ups is a particular concern for the clinical team. When we've run the numbers, we've got circa 2,500 follow-up appointments and about 1,300 people awaiting a follow-up, on the follow-up list in total. So that would feel like we've got sufficient capacity to manage the demands of that workload potentially, and so they're working through what the balance of that is with the new patient demand. Is the longer waiting times as well as starting to are obviously manifesting themselves in the new patient waiting times, and we're going to have to look at how we do increase capacity. We have got vacancies and gaps in that team, so that there will be scope, I think, to look at how we increase the overall capacity within the team, but they're still in the process of doing that work and thinking about all of the, as I say, as we would look at a normal waiting list, thinking about all the impacts of DNAs and cancelled appointments, all those sorts of issues, how we maximise, how we make sure what capacity we do have, we maximise and don't waste and are efficient in the use of. PBIS, I don't think that's the implementation date. We're still working through that for the task and finish group, but maybe I could come back to you specifically with of course. With that. Was there a final point?
WPAS.
WPAS. I'm in relation to community paediatrics.
Yeah, there's reference there that in the action plan, couple from the end, there's been issues with the implementation of WPAS, I think, and the use of it. Is that working optimally, and is it doing what, is it working optimally, and is it doing what it's supposed to be doing?
Maybe I could come back to you on that, Paul, because I think that probably links to some of the pathway links into mental health as well. I just want to make sure I give the right answer and not mislead in any way.
Could I just make a further point following on from that, really? I think it's good to know the plans that are in place. I think it would be useful to see some trajectories as to how and when we're anticipating to see improvements as a result of the actions that have been taken.
Okay.
Yeah, so on that, I should have said when I was introducing the paper, one of the expectations I've set for the task and finish group is that we would be in a position in time for the September board, if you wanted that to come back here publicly, to present the outcome of that demand and capacity work and the associated improvement trajectories around it.
Okay, we'll take that away. I need to have a look at what's planned for.
Whether it comes to board or one of the committees, I'm going to be.
Can I just ask a question? I suppose I'm just seeking assurance, because it's not referenced in the paper, that there is the link with the Child and Adolescent Mental Health Service. There's a link into the implementation of the NEST framework. Can I have sure that community fees are well linked in there, because this doesn't reference that?
So there are links made, certainly in terms of the operational management arrangements. The teams are working together on looking at these issues, on the totality of the pathway, and certainly that transition between paediatrics and adult mental health and is something that is a very key issue that they need to address and work on. I do think there is some work for us to do based on some of the email correspondence I've seen and some of the conversations I've had in working with the two clinical teams to make sure we join that up much better, though.
hand next?
Yep, that's all part of that process, sorry, yep.
That's fine. Okay, thank you. So we have the recommendations there. People happy to accept those? Thank you. So Andrew, it's you again. And we're on to 4.3, which I think we have Lauren Lloyd and Liz Carroll on to help you with this, perhaps answer any questions. Do you want to make an introduction?
Yeah, so I'm pleased to say joined by Liz, Warren and Sarah from as the Mental Health and Learning Disabilities triumvirate. I'll just say a couple of words because I'm sure partly because we've gone through in detail in board seminar the improvement trajectories for the waiting times position, but also in part this is some of this paper is providing a bit of a follow-up to the paper we brought to board in May as well, and some of the outstanding issues that the board wanted more detail on. It does try to address in particular the transforming mental health update. So one of the comments when we brought the paper last time was that it was not clear how the actions we were describing linked back to the original recommendations. So we've tried in one of the appendices to this paper to set that out very clearly. We've included the paper that we discussed in detail at board seminar around the improvement plan and the trajectories work. There is, as we've identified there, an issue in terms of neurodevelopmental and our ability to truly develop a forecast at the moment because of some of the capacity and demand imbalance. So I'd want to flag that, but in the other cases of the other measures, there are trajectories there that get us back to or work us back towards target by the end of March. And we have started to see some improvement in some of those areas over the course of the last month, as we would have expected with the actions we've put in place. I'll pause there and I'll see if there's anything that, or just go straight to questions, whichever you prefer.
Well, I just wonder if there's anything our colleagues from mental health want to add to that. And also one question we've already had, Liz, I wonder if you could cover, is if we're getting feedback from the Mental Health 111, if you've had any specific feedback.
Yeah, yes, so I think Andrew has outlined the context of the paper as it being a follow-up paper to one that had previously come. And as people will be aware, the board seminar paper is attached as an appendix. So what we've really concentrated on this time is the performance in the IPTS, CAMS and psychological autistic spectrum disorder and our integrated psychological therapies. So, I think and just in relation to the operational update that was given by Andrew and Jill earlier, it's important to note that, mental health services have been impacted, by COVID. We've had, in terms of our wards, our community services, etc. So just to get in that into context. So if I start with the part 1 and the SCAMS measures there, we have seen an improvement in our performance in line with the trajectory we have set ourselves. Whilst the improvement is mostly in the first part, that will become easier for us to sustain, but this then increases those numbers of people who are waiting for part B, so we need to monitor that quite closely really to ensure the improvement that we've anticipated will be sustained. Obviously, we're working with the delivery unit to learn from other health boards about, approaches they may be taking. And the delivery unit are soon to be undertaking a primary and secondary care review for CAMS across Wales. So the next area then is the integrated psychological therapies, and the overall position shows that the total for the directorate of waiting times for psychology and not just for the IPTS service. And we are currently experiencing some challenges in older adult mental health psychology and learning disability psychology, which we are seeking to address. I think of note there in relation to the integrated psychological therapy services and the large number of DNAs that we've seen in that service, and our service delivery manager there is looking to investigate that. Sorry, I could see a message there from Mandy. Sorry,
Judith. The sound quality isn't very good, I'm afraid.
We're losing you as well. Can I stop you, Liz, because everybody has seen the paper and read it. I just wonder if you could go to questions, because I know some colleagues want to ask questions, and I think, because I say you're breaking up occasionally coming in to us, so I'm missing some of the words. So is that okay? Did you ask you a question about 111, the mental health 111? Yes. You could just give back on that, and then I'll open it up for other questions.
Mental health, a single point of contact went live 20th of June, so that's the mental health 111, and as Andrew said, with the first health board to go live with that. And as the recruitment improves, that will become a 24/7 sort of service as well. Currently it's 9 till 11:30. And the professional line for GPs, police, social workers, education, WAST, community drug teams and drug and alcohol services will be live available from the 8th of August. And that will be a local number, and a band 6 mental health practitioner will man the line to offer and support to partner agencies. As Andrew said, we've had some close links with primary care in terms of the clusters, because some of the calls that have been coming through have been for prescribing or drugs being changed. So we've worked with primary care to just kind of to alleviate those calls coming through. And the other thing that the service is experiencing is they're getting lots of queries about dental, because when they hear the message, they are interpreting mental for dental.
Okay,
that's to be obviously feeding back with colleagues.
Okay, thank you.
In terms of the volume.
Yeah, no, I'm really sorry. I think it's our link. It's our link to you that means we're missing some of this. So I am going to just see if there are any more questions, and perhaps you could send that response through to Joe, and then we can send it out to members. I'm really sorry about that. We're in a outside premises, so we're having a few problems with the link. So I'm going to open it up for questions.
Members of the public can hear Liz and her colleagues really well. It's just in this room, so apologies, Liz.
So the public can hear you, it's just we can't very well. Right, I have got questions, so John, you wanted to come in?
Thank you very much, Liz, for the report. I can see that a significant amount of work has been done, particularly in terms of the dashboard that you put together. That does give us a clear indication around quality and safety, workforce, etc., which I have to say provides assurance to me. However, whilst we now know that data and our position in terms of the performance, what I read in the report is that much of the performance is predicated on vacancies being filled, new staff being appointed, and in each of the targets that you note, where there's a trajectory of meeting the target, there's always this rider depending new staff or staff being in to fill vacancies, which is fine. My question is, what confidence can you give the board that we will get staff in order to fill these vacancies, and that we will be appointing so that these targets can then be achieved?
Thank you. I think, it's fair to say we've seen some fairly successful recruitment in our CAM service in particular over recent months, and, obviously onboarding, etc. And we're trying to build that in when we're developing and formulating the trajectories. In terms of our integrated psychological therapy services, although there's a national shortage of psychologists, a lot of those interventions are provided by staff from mental health practitioner background, so nurses, occupational therapists, etc. So we tend to grow our own workforce, in terms of the delivery of some of those psychological interventions. What I haven't called out, and I was going to raise it today, is I think ASD is a whole different ball game. We've moved from having 20 odd referrals when that service first started to being in excess of 70 per month now. You know, the numbers that are coming through and that we're all eligible to have the assessment undertaken. I think the only way we're going to manage that waiting list, if I'm perfectly honest, is to go out to recruitment at risk for substantive posts. And as that waiting list settles down, then we would look to deploy staff to other services. But I don't know that we can put an awful lot of faith in outsourcing. It tends to be quite expensive, and you know, at least we can oversee the quality of the assessments that we're providing if we have our own. I won't recruit into those posts on fixed term.
Okay,
sorry.
Thank you. No, it's okay. It's not your fault, Liz. It's the connection was here. Paul.
Yes, it's sort of, I think, started to touch on the question I was going to raise in relation to ASD assessments, where we were talking about the peak uses per month. 87 referrals per month and 40 is our internal capacity. And even if we outsource, and you just highlighted some of the difficulties in doing that, we're only going to be doing 150 a year. So that's going to mean that the list is actually increasing by approximately 40 per month over and above where it is at the moment, even if our outsourcing is successful. And so the position is getting worse, we're projecting the position is going to get worse, not better. And we'll be in a worse position in 2025 without action than we are now. And the position at the moment is not good. So clearly we need some action taken in order to address that. And I hear all you say, but clearly that situation is not acceptable, I would suggest.
I agree that we need to do something, you know, on a substantive basis, I think, to address this issue. We, as part of the workforce in the ASD team, we would be able to recruit psychology assistants to support some of the more senior members of staff, and that tends to be an easier recruit into from psychology assistants. But I think, you know, unless we increase that team and increase the capacity there, we can do all the work we want with the delivery unit. We know that the demand is such that we're going to have to increase that workforce, and we could potentially use our SIFT funding, some availability from the SIFT funding to enable us to do that. As things stand at the moment, I see that as the only way forward and the only solution.
Okay, I think we'll need to come back to this, if not at the board, certainly in committees. I haven't got any more questions, Liz. The board is asking, the recommendations are there for us on page 10 of the report. Content to note those recommendations, and apologies again for the fact that we've got a difficulty with the connection. We're in an off-site venue, but thank you very much for all the papers, and thank you for coming and showing that there is real progress in areas, even though we can see that there are significant challenges still to be addressed. So thank you very much.
Because I think I